Okay, so hi, hope you all of you are doing great. I'm Dr. Marwa, and I welcome you all to this ACE IBQ session where we discuss and focus on those important questions, those image-based ones which are usually coming in the exam. And as you know, the exam is more clinically oriented, so let's make the images talk to us. That is what I can say. And what I'll do is I'll not only tell you the answer to a particular image, but I'll also tell you the cues that help me identify that, and then also some related aspects from pathology as well as the treatment aspect, because lots of time these questions may not be asking you per se the interpretation of the image, but they might actually ask you one step ahead as well. So keeping like one step ahead of the common trends, let's start with the very first question, and meanwhile you can let me know regarding the audio and the visual part if it is perfectly fine. And my objective is to make your clinical reasoning. I know you are brilliant chaps and you're doing well, but then my job is to fine tune that clinical reasoning and integration of the visual cues with the core concepts. So, welcome everybody, and I think we're good to go. Fine, perfect. So first we'll begin with the ECG based analysis, Ram Kaushal, and I think we're good to go. So let's start with the very first question. I'll zoom into the image so that you are able to analyze the information relatively better. Like you can see that there is always a P wave and then there is a QRS complex present. In fact, there's no Q here, RS complex is present. So what I can say at the moment is that the patient of mine is in a normal sinus rhythm, and every time you check out an ECG, you need to check out in lead number 2 and calculate the heart rate. Now, calculation of heart rate is a 5-second job. 5 second में you can analyze it. The formula for that is 300 divided by RR interval. So all you need to do is every time they give you a ECG in the paper, first check out whether the patient is having a tachy or a bradycardia, because that will make your job easier, because either he will ask you tachyarrhythmias or he will ask you bradyarrhythmias. So in this particular case, as you can see, that the heart rate of the patient would be something like about a little more than 40 beats per minute. So my patient is having a bradycardia. But when you scan through the ECG, you will notice that the RR interval is remaining constant. There is no missed beats present. And more importantly, P wave is present before every QRS complex. So our interpretation is what Saqib has said very beautifully. That would be a simple sinus bradycardia. And the reason for the sinus bradycardia can be that our patient could be an athlete, he could be doing a running on every single day. So lots of time, like people who do regular exercise, they tend to have is a heart rate lower than normal. Just like you do MCQs daily, you'll become mentally more stronger, and then your heart rate, like normally, if somebody goes into the examination without any preparation, the heart is literally gonna pound in the chest. But those guys who are gonna be practicing questions on daily basis, like you are doing with me at the moment, then gradually that I would say that palpitations would go away and your heart rate is going to be much more stabilized, and your even thought process will be relatively much more, I would say, your thought process is going to be more streamlined, and that's, I think, the most important part. So the first one is a very good interpretation, I think, sinus bradycardia. No, old age is a reason for development of sick sinus syndrome, but yeah, sinus bradycardia most of the time, the reason for this would not be given as old age, but would be answered as high vagal tone. So I will be showing you the ECG of sick sinus syndrome in like couple of minutes from now, but at the moment it is the sinus bradycardia with a high vagal tone. Now moving to the second one, this is again a very quick interpretation. If you check out the RR interval in lead number 2 once again, which we call as the rhythm strip, you will notice that a little more than 2, I can say, heart rate is present. So this particular chap, what is present is 1. I can say that the heart rate of the patient is more than 100, because if I divide 300 by, for my mathematical calculation, if I take it as 2.5, then the heart rate would still be 125 beats per minute. Now, every time you are gonna give you this particular ECG, and this has actually been asked in the exam, you have to see whether it is a PSVT or not. In PSVT, either you have retrograde P waves, or for that matter of fact, you might be having is a hidden P wave. But if you check out the ECG here, you can see the T and the P wave separately, because the T and the P waves are visible separately. So this is not a PSVT. Your answer in this particular case would be sinus tachycardia. Very good. I think most guys have got this one correct, that this is not a PSVT, guys. I would have answered it as PSVT if the P wave was not visible, if it was a retrograde P wave or it was a hidden P wave present. So भाई recorded नहीं है, come on यार. Sinus tachycardia is the aspect that you need to remember for this place, or भाई पढ़ लो. Sinus tachycardia, well, why would this be occurring in a patient? Then two of the very common causes where sinus tachycardia would be given is one, thyrotoxicosis, and the second scenario where they would be giving sinus tachycardia to you would be for anemia. I mean, the beauty is that if I can do live, it can look organized like a recorded, then theek hai bhai, I'll take it as a compliment. So, okay. So sinus tachycardia, the two important causes to be present are Graves and anemia, where there would be a compensatory tachycardia present. Another one, important one, where you could be having sinus tachycardias, congestive heart failure. So we are sorted for the second question, and I think most guys have given this one correct. Yeah, anxiety, palpitations, high altitude, all would contribute to sinus tachycardia. So good, very good. Fever as well, absolutely great. Let's now move on to the third one, which they love to ask, and this is where we are gonna be focusing on the RR interval. And the third ECG that you can pick up, you will notice that the RR interval is not constant. अब क्योंकि RR interval is not constant, तो भाई हमें सोचना पड़ेगा कि irregular RR interval कहाँ पे होता है. अब irregular RR interval जो है वो दो बार ही पढ़ते हो आप. एक होता है multifocal atrial tachycardia और एक होता है atrial fibrillation. Because in this ECG, when you check out the RR interval is variable, and at the same time the P wave is not visible because of the fact that there is an absent P wave. In fact, there's a twitching happening. No, I mean, you can check out the twitching part that is happening here. So the P wave in the ECG is absent, and this is one of the commonest sustained tachyarrhythmias that we see in our practice. Remember, the word would be sustained tachyarrhythmia in clinical practice is going to be atrial fibrillation. And for this question, yep, irregular pulse would be given most of the time. The clinical scenario given in this particular ECG will be of alcoholic who goes to a party where he does binge drinking, and then he ends up with what is called as holiday heart syndrome. Now, the trick in the question would be that what he will do is he can ask you the following possibilities, which I want you to understand. Like in last time's paper, one of the FMGE exam question I can put in it, where the blood pressure of the patient is crashing and it's an acute onset atrial fibrillation, we have to go in for a cardioversion. But otherwise, if the BP is stable, then we can go in for patients like if my patient is stable, then I'll be using beta blockers as the initial treatment for this patient. What I mean by the word stable is that the systolic blood pressure of the patient is more than 90/60. So if it was a crashing patient, hemodynamic instability, I'll think in a cardioversion. But of a recent onset atrial fibrillation and the blood pressure is more than 90/60, then we have to answer beta blockers. But in NEET PG, there was a trick. In last time's NEET PG, there was a question on atrial fibrillation, irregular RR interval given, and then बहुत smartly he mentioned regarding presence of bilateral crepitations in the patient. Because of the fact that there would be crepitations in the patient, there would be a pulmonary edema present. Then in a setting of pulmonary edema, we will not answer beta blockers because beta blockers are contraindicated in a patient of acute pulmonary edema. So for those of you who are sitting for both FMG and NEET PG exam, please comment in the chat box. I would like everybody to comment. Would you be giving digoxin? Will you give verapamil? Will you give diltiazem? Let's select three options: digoxin, verapamil, and diltiazem in a patient of atrial fibrillation with congestive heart failure. Okay, very good. I'm having a lot of very good answers also, but I think, okay, so first and foremost, if a person is having a heart failure, there is a compensatory tachycardia. If you will give verapamil or diltiazem, you will put the brakes out, right? आप बंदे का गला दबा रहे हो यार, तो heart rate control मतलब करने के चक्कर में you are literally squeezing the heart rate, and heart rate is what is keeping the person alive because that will help in clearance of the pulmonary edema component. So what we will do in this patient would be digoxin. So yes, guys, I think Kaushal was the first one to mention it, and I would like to reiterate the statement for everybody in questions of atrial fibrillation. If there is gonna be unrecordable blood pressure, this is what was the FMG exam question. He said recent onset atrial fibrillation in alcoholic like binge drinking, and then there's a hemodynamic instability. We will select the sync mode and we'll go in for a synchronized DC shock. In NEET PG, what he said was that this was a long-standing atrial fibrillation in a patient, like the person is having cardiomyopathy, and then he said the person has gone into acute heart failure as well. And he said, what is the initial treatment to be given? The blood pressure of the patient was pretty decent. Then in these circumstances, we will be giving digoxin for this particular patient. See, if a atrial fibrillation is of previous 48 hours, then it will not cause clot formation. But if it is long standing, then it will cause clot formation. Then we will not do, then we will not be giving synchronized DC shock, because the problem is that clots can go into the brain of the patient. So answer would be digoxin. But yes, if it is bronchial asthma, Like suppose he gives you a question of long-standing atrial fibrillation, and he mentions in the question that person is having asthma or if the person is having COPD, then your answer of calcium channel blockers is fine. So if you can get these three concepts right, you are perfectly suited to get these questions right. And yeah, because there is risk of clot formation in these patients, so we also use a score that is to decide the need for oral anticoagulation. So CHAD S2 VSC score is used to decide the need for oral anticoagulation in this patient. So I'm having very good inputs, and I'm really happy that you guys are able to figure these out. And yep, CHAD S2 VSC score, we use it to decide the need for oral anticoagulation. Okay, additional point again for those who are sitting for NEET PG, that if it is going to be rheumatic heart disease, then do not answer warfarin. Do not answer newer oral anti-clotting agents, then answer warfarin. But if it is a non-rheumatic etiology, if it is mentioned as non-valvular atrial fibrillation, then you can answer the novel oral anti-clotting agents like rivaroxaban, apixaban, dabigatran, for that matter of fact. Very good. I think even for FMG exam, this is very much valid. So I think the topic asked was uniform, but then I had very good inputs with respect to these questions. So slide number 3 is very much sorted. Great. Let's move to the fourth one. In this particular question also, a very classical one, you will notice that the RR interval of the patient is variable. So I'll just show you the areas where the RR variability can be seen. And therefore, the first thing I want to emphasize is the exam, whenever they give you a 12-lead ECG, just check out lead number 2 at the bottom, the rhythm strip, calculate the heart rate. At least try to calculate the heart rate 2 times so that you are able to not miss the irregular RR interval. Now, in this particular ECG also, you will notice that the RR interval is irregular. But the catch is that there is presence of P waves, and the P waves that are present here, if you check out the height of these, you will notice that the height and the physical appearance of each of these P waves is changing every time. So because we are having three different, I'll just zoom it in. Yes, I think you can see this now. The height of the P wave, the duration part is changing. So since I can say the physical appearance of the P wave, the morphology of the P wave is different. Therefore, the answer in this case would be given as multifocal atrial tachycardia. More than 3 morphologies of the P wave are seen in this case. So the interpretation is MAT, that is multifocal atrial tachycardia. And in this case, if he will say, like it will be a two-step question, he will say, how would you do a rate control in this patient? So I'll not be answering S-full-all because this condition is commonly seen in COPD patients. It is the hypoxia of COPD, which is the trigger for development of multifocal atrial tachycardia. As I've told you that we don't give beta blockers in a patient who's having COPD. What we will do in this case is we can be using diltiazem, we can be using verapamil for management of this patient. And obviously we need to treat the COPD component. Now we move to the next ECG that you can see here. So first and foremost guys, हमेशा lead number 2 में heart rate count करना. अगर टैकीकार्डिया होगा तो नेक्स्ट स्टेप क्या होगा, देखना है कि आरआर इंटरवल रेगुलर है या इरेगुलर है. मोस्ट ऑफ द टाइम 10 सेकेंड्स में आपका क्वेश्चन सॉल्व हो जाएगा. मैं रिपीट कर रहा हूँ, जस्ट चेक आउट द हार्ट रेट, then subsequently check out whether, because it will usually be a tachycardia scenario, tachyarrhythmia scenario given to you. You have to just see whether the RR interval is regular or irregular. If it is irregular most of the time, check out whether P wave is present or is absent. If P wave is absent, atrial fibrillation. If it is present with a variable morphology, it is multifocal atrial tachycardia. And now we'll focus on the next one where you can see very characteristic, I mean absolutely perfect. You can see the presentation in this case where I'm showing before you is the flutter waves which are present, and these flutter waves are characteristic for atrial flutter. These are the sawtooth pattern that you guys have to be familiar with. So comment in the chat box, would you like to call it a 3:1 or would you like to call it a 4:1 conduction? Quick representations on the board please. On in your chat box please. In a case of atrial flutter, you can see this sawtooth waves, right? You can check out these sawtooth waves which are present. Considering those sawtooth waves that are present, would you like to call it a 3:1 or would you like to call it a 4:1? Okay, so Kaushal was the first one to answer even in this one. When you are able to see such 3 waves, then just add 1 and don't answer 3:1, answer 4:1 conduction. No guys, it is like this. If you are able to see 2, that means 2 are bouncing off the refractory AV node and 1 is getting conducted. So it is like if 2 waves are seen, answer it as 3:1 conduction. If 3 are seen, then answer it is 4:1 conduction. So you just need to be, aware of this. Though this is a technical concept, but still, I got this opportunity, so I thought I should say this. And I've said this in image-based questions, even in the app, but doesn't matter. Like at the moment, atrial flutter. Every time if you see 3 waves, you will say 4:1 conduction present in this case. And if I count the heart rate in this guy, let's do the heart rate calculation also. The heart rate of this guy would be something like 1, 2, 3, 4. So the ventricular rate of the patient, when I say heart rate, no, the ventricular rate of the patient would be something like 75 beats per minute. I'm writing 75 because I can count like 4 large squares present. Help me out with the atrial rate, guys, now. If it's 4:1 conduction, you need to multiply that by 4, no? So the atrial rate of the patient would be 300 per minute. So what you can see here is that the vagus nerve is working very beautifully. Atrial rate is 400, atrial rate is 300, and the ventricular rate is only 75 per minute. That is thanks to the drugs. This guy would be on medication, and that is why the heart rate of this patient is stabilized. So this particular guy has already had a rate control. We've already done a rate control in this case. Now we need to go for rhythm control, and for the rhythm control in this patient, again, amiodarone will be used both for the management of atrial flutter and atrial fibrillation. It is the race which should be used if it is going to be a long-standing atrial fibrillation, or if it's going to be atrial flutter, that is rate control. Then it's going to be anticoagulation, chemical cardioversion, electrical cardioversion. If chemical cardioversion fails, that is when electrical cardioversion would be done. But good one, guys, here this would be a 4:1, and yeah, the intensity of DC shock would be a low intensity DC shock. So we are sorted for atrial flutter. Let's look at the remaining ones, easy ones here. And okay, moving to the next ones. Okay, great, guys. Let's move on to the next one. I think time is precious. This would be like 1.5 large squares approximately. So I'll just write that once again. The distance between R and R, this is gonna be like 1.5 large square. So the heart rate of this particular guy, the heart rate in this particular guy is varying to be something. Yes, this time the heart rate is about 200 per minute. Doc, we'll not call it electrical alternance, because in electrical alternance there is a normal sinus rhythm. In electrical alternance, there is a normal sinus rhythm, and you should be having is a low voltage ECG. Here, there is no voltage, low voltage. Definition low voltage is R plus S wave height summary, or R plus S should be less than 5 millimeter. I'll write it down for the convenience of everybody. Like, why is this not gonna be low voltage? Then R and S should be less than 5 millimeter for calling it a low voltage ECG, which is not present in this particular case. So I'm just writing it, putting a line over it. And yeah, you are able to see retrograde P waves present. And that retrograde P wave, either it will say the word hidden P wave, or there might be a retrograde P wave present. So the diagnosis in this case is a paroxysmal supraventricular tachycardia. And again, what will happen in the question would be that he will ask you whether it is a hemodynamically unstable patient or whether it would be a stable patient. If it is a hemodynamically unstable patient in this particular case, what you will do is you would go in for a sync mode, and you will be doing a cardioversion, that is a synchronized DC shock. But if it is a hemodynamically stable patient, the cutoff for stable would be a value of more than 90/60. If it is hemodynamically stable, then go in for vagal stimulation first. Vagal stimulation would be like carotid sinus massage, or instead of carotid sinus massage, another thing can be like a modified Valsalva maneuver where you blow into a syringe. Instead of this, we can also use the face ice pack. So vagal stimulation has to be there. And after vagal stimulation, then we need to give adenosine to this patient. This would be followed by a saline push, because adenosine most of the time, like you're giving 6 milligrams. So this is again a practical aspect that we have to give a saline push after adenosine has been given. But in all questions of PSVT, my request is always check out the blood pressure. If it is less than 90/60, you have to give a sync mode of DC shock, that's cardioversion. If it's more than equal to more than 90/60, then what you need to do in this patient is ensure that your patient is, if it is like hemodynamically stable, then vagal stimulation adenosine is on its way. Yeah, DBK, you're perfectly right. We don't give carotid sinus massage in a patient having a carotid artery bruit. So actually, atherosclerosis would not be a very correct word, but since it came up in the chat, my job is to say this, that we don't give carotid sinus massage in those patients who would be having is presence of carotid artery bruit. Okay, moving ahead. Moving to the next one, we are having this broad QRS tachycardia, very characteristic. And the moment I say like whatever is going up is R, what is coming S is down. So yeah, catheter ablation for prevention causal. That's a good input. In those circumstances, yeah, most of them are of equal height. No, the baseline might be a little variable, but I can call it premature ventricular contraction because only RS is happening. You are aware of the fact that if you have 3 consecutive premature ventricular contractions and the heart rate of the patient is more than 100 per minute, that implies a working definition for VT. That would be a ventricular tachycardia. See guys, the baseline is, I would say, a little off, I can say, but yep, this would be a monomorphic ventricular tachycardia. No, I'll show you the polymorphic also. But at this moment, we'll call this a monomorphic ventricular tachycardia. And the more important thing in this particular case is that most of the time patient will be pulseless. So we will have to go ahead with defibrillation in this patient. So lots of time these questions would always be mentioning that patient is having PSVT and would you like to go in for a sync or a non-synchronized DC shock? So our answer would be a non-synchronized DC shock. That is a defibrillation would be required. Yes, you're right. Here we can be having is a presence of Canon A waves. So a lot of people are able to solve this MCQ even by saying the word Canon A waves, which tells me that there is a AV dissociation. In fact, Canon A waves can be present both in point number 6, PSVT, as well as in case of a ventricular tachycardia as well. But the core aspect is that the QRS duration in this case would be relatively broad. So let's move on to the 8th one now. Yes, this is the one where there was mention of the fact, and he also mentioned that the patient was having an electrolyte imbalance. Like in most questions that would be given to you for Torsades D pointers, not only will you be able to see a broad QRS tachy, but he will usually be mentioning regarding either he'll talk about those banned drugs, no, like in NEET PG, I think last time he mentioned about estamizole, or he can talk about cisapride or macrolides, or like macrolides in combination with ketoconazole, macrolides in combination with ofloxacin. So most of the time, like, if we are talking about hypokalemia, hypomagnesemia, cisapride, estamizole, macrolides in combination with fluoroquinolones, that is when we have to think in terms of TDP, that is Torsades D pointers. Even this patient is having a broad QRS tachy, no doubt about it. But at the same time, what is happening is that the amplitude of each one of them is variable. I mean, we can see very significant variation in the amplitude of the RS complexes. So this time, our technical interpretation in this case is a polymorphic ventricular tachycardia. And then to ask you the drug of choice, what he'll do is he'll ensure that the patient is hemodynamically stable. Any crashing patient, it's anyway non-synchronized DC in this case. But if it is hemodynamic stability given, then magnesium sulfate is what he would like to hear before you. So magnesium sulfate also comes up in the discussion multiple times: severe acute asthma, polymorphic ventricular tachycardia, to name a few where we use it. Yes, even in severe acute asthma, magnesium sulfate would be used. So good answers till now. Let's move on to the next one, the 9th one on the board. And the hint is that this patient is taking treatment. This is a child. He has a valvular heart lesion and he's treated for heart failure. Not exactly. I would say that this person is having tachycardia at the moment. Yep, in between we can see some runs, but that means that patient might have been cardioverted as well. But when the run is occurring, then there's definitely a tachycardia present. Okay. Moving to the next one, what you can notice is this huge premature ventricular contraction. I mean, you can see the R and the slurred S wave. This broad R and the slurred S wave is that premature ventricular contraction. And you can see that this is a normal sinus rhythm. That is anything which has a P followed by a positive reflection of a R. I'm going to call it a normal sinus rhythm. And I've given the hint also that the patient of mine is taking treatment for heart failure. So if you have normal sinus rhythm, I'll do this once again. This is NSR. You can see the normal sinus rhythm, and you can once again see that broad R and that slurred S coming up, because this would be a premature ventricular contraction the wave could have originated from the bundle of phase. So when we have alternative such patterns, we call it ventricular bigeminy. And this ventricular bigeminy is what we encounter mainly with digoxin toxicity. I think everybody is familiar with that. That one of the commonest arrhythmias or digoxin toxicity always asked in your paper is ventricular bigeminy. But make note of the fact that digoxin can also contribute to development of bradycardia. So once he asked about bradycardia, and I mean the ECG showed a bradycardia. He said, "What will you do?" The BP was low, so we'll give atropine in a scenario wherever there's a bradycardia. But in a ventricular bigeminy, the drug that we'll be using in this patient would be lignocaine. Doc, that's a separate MCQ. You know that hockey stick sign that we talk about, that's a totally separate ball game. I mean that whenever I say that we are gonna be talking about hockey stick sign, that's a feature of ST depression seen with digoxin, but that's not toxicity. Whenever we say digoxin, what impact does it on the ECG? So digoxin causes vagal stimulation, so there's a PR prolongation. Along with this, there can be a ST segment depression that is coming, and even a QT prolongation can be seen. So why not digibind? For digibind is to take the care of digoxin toxicity, but to stabilize the cardiac. I mean, in this particular case, for the management of this patient, what we do is give IV lignocaine. And the main problem was that IV digoxin was given as a loading dose. What I was trying to say is the patient was given digoxin as a loading dose, and following with that loading dose, this arrhythmia could have started. So we'll give lignocaine to stabilize the cardiac membranes. And yep, the main treatment for digoxin toxicity would be given as digiband, but the primary answer in this patient would be given as lignocaine to stabilize the excitability of the myocardium, which is responsible for this premature ventricular contraction. So our good answers and a healthy discussion here as well. Yeah, we can use phenytoin as well. That's again that's the only example where a neurology drug is used in cardiology. I mean, they can put up those questions as well, especially those of you sitting for NEET PG. You need to be vigilant about the fact that he might be talking about a patient on loading dose of digoxin, and maybe it was administered twice due to some mistake, technical mistake, or clerical mistake in the files, and because of this there could be arrhythmia run that can be seen. Okay, yeah, Suvarna, you have a point there, but then from the academic perspective, we need to stabilize the myocardial excitability initially. Okay, so moving to the next one, a very characteristic ECG, which is given here. So I'm waiting for your answers in this particular case. You can also notice that the patient's RR interval, even in this case, is changing. Like if I count the RR interval here, this would be 5, a little more than 5. So the heart rate is dropping to less than 60 beats per minute. There's a bradycardia. And then here you can notice that the heart rate of the patient is a little less than 100. So considering the fact that the heart rate was less than 100 and then it is decreasing to less than 60, we need to think in terms of possibility of a heart block. And when I talk about the heart block, what you need to do is, one option is check out the PR interval the first time and the second time and the third time. And when you check out this PR interval, what you will notice in this patient is that the PR interval of this patient is showing a significant increase. Like if you check out the PR interval here that I'm marking at the moment, the PR interval is showing a substantial increase as compared to what was present initially. So because we are having a PR prolongation, this would be intranodal conduction block. That would be a presence of Mobitz on heart block. So yes, guys, you got it right. I mean, I did have inputs of Mobitz to heart block as well, but the pattern is repeating once again. You can again notice that there is a serial prolongation that is occurring, and following that, once again, like the heart rate of the patient is becoming slow at this moment. This is where the drop beat can be given. So in some MCQs, he might mention the word drop beat where I put the vertical arrows. But even if it does not mention this, this would be a Mobitz 1 heart block. No, we'll not call it a type 1 heart block or first degree heart block, because that is having a prolonged interval which is constantly more than 200 milliseconds. But the key word in this particular question would be a serial prolongation, which is responsible, and had a very good input there. The very good input was Wenke-Bach phenomenon. So let me just write that as well, because this would be ready reckoner for you when you have to revise the ECG. You can just use this document subsequently. maybe 5 minutes, maybe 10 minutes, and you get through the common rhythms which are present. So the main thing is you notice that there was a slowing in the heart rate, there was a missed beat. That missed beat word may not be given. And yes, another hint is a lot of these questions might mention patient is already on beta blockers, and I mean the physician had given maybe 50 and the patient took 100 or even much more than that. The chemist dispensed a double strength tablet, patient took too much of beta blocker, then beta blocker overdosage can result in development of Morbitz 1 heart block as well. Okay, so yep, guys, you were waiting for Morbitz 2, so I give it to you. I mean, in Morbitz 2 heart block, you will notice that the PR interval will not change. It will remain constant, and then you can see a T followed by a P. And again, you can notice the constant PR interval that is occurring. So once the PR interval is constant and we have this dropped beat coming up here, then we will be saying that this would be a Morbitz 2 heart block. Obviously, quickly comment in the chat box which is more dangerous. Morbitz 1 heart block is more dangerous or Morbitz 2 heart block is more dangerous. Quick inputs, please. One, you can just comment in the chat box 1 versus 2, which is more dangerous. Yes, Morbitz 2 heart block is more common after especially a myocardial infarction. It could be like a septal myocardial infarction, and Morbitz 2 heart block is relatively much more dangerous. Yeah, because there's a sudden drop. No, I mean, just check out the RR interval here, man. Just check out the RR interval here. I mean, if you boxes count karte karte thak jayenge hum, right? I mean, this is gonna be a dramatic decrease in the heart rate. I've counted till 8. It is a little more than 8, but still for my calculation purposes, 300 divided by 8, that's gonna be very slow. I mean, 30s, right? So that's gonna be 30, between 30 to 40. That's gonna be always a cause of concern because you can see the tremendous decrease in the heart rate. Okay, moving to the next one. Yeah, TCP would be required in that. Transcutaneous pacer would be required after atropine. In fact, most of patients of Morbitz 2 heart block would be requiring a TCP or a TVP. That's a transcutaneous or a transvenous pacemaker. Okay, cool. Let's move on to the next one. Again, it looks like a Morbitz 2 heart block only because you can notice that there is a sudden increase in the RR interval in this patient. There's going to be a drop beat present here. If I check out the PR interval after and before, it looks to be equal. So you guys can comment here. I'll do the meanwhile the markings here as well. Like what I want to say is that this is a conducted P wave. You can notice P followed by a R wave, and then there's a bit of a T wave inversion present. So I can say conducted P wave. But the next one that I'm marking before you, this is a non-conducted P wave, which is followed by a drop beat or a missed beat. So what is happening is alternatively, like one P wave is getting conducted down, the other one is not conducted down. This is a cousin brother of Morbitz 2 heart block. This would also be an infranodal conduction defect. And yeah, you would be answering this as 2:1 block. Very good, very good. This would be called as a 2:1 block. This is a differential diagnosis of Morbitz 2 heart block. Especially if you're sitting for FMGE exam, just get Morbitz 1 and Morbitz 2 right. If you're sitting for NEET PG, then I want you to be very careful regarding before you mark Morbitz 2, just check out where there's a trick in the question, because in Morbitz 2, there would be three, four, five normal conduction. It's like normal, then a drop. But in 2:1 block, it's a conduction, non-conduction, conduction and alternatively happening. So that's why we call it a 2:1 block. Whereas in Morbitz 2, it's like conduction, and maybe conduction till 100 times. And then there's a sudden block where there's a tremendous decrease in the heart rate of the patient. So very great. I had good answers there. Well, we put in a pacemaker, no? So we coming to that, like somebody commented, we go in for a dual chamber pacemaker. So here, this is question number 13 is pure FMG. So if you're an FMG student, you need to listen to me very, very carefully. He mentioned regarding old man having syncopal attacks. Whenever he is getting up from the bed, he is having a syncopal attack. He uses a toilet seat, is a syncopal attack. And then he gave the ECG and he mentioned theory also. Normally, the number of P waves in the question is equal to the number of the R wave. But here, if you check out the number of the P waves, it is much more as compared to the number of R's here. I mean, I'm gonna mark out the R here. This is like a R with a broad slurred S. So 2, this is 3, this is 4. Whereas the number of P waves is much more. So if P waves and R waves are not matching, he mentioned that in the theory as well. And I think most guys were very quick to latch on to that hint. And the diagnosis in this case, where there's a postural hypotension occurring, would be given as Stokes-Adams syndrome. We have AV dissociation in this case, and because of this AV dissociation, because the two chambers of the heart are working independent, so what we have to do in this case is, and this is also what they've asked, that we'll be going in for a dual chamber pacemaker in this particular case, because the two original pacemakers of the heart are doing a mess of the situation. So we put in a computer that's now going to ensure coordination between the two chambers of the heart. So this is going to be like a complete heart block, and this would also be having is the presence of a Canon A wave present. So Canon A wave can be present in tachy, that is VT or PSVT, and they can be present in a Brady as well. That is the current point of our discussion, that is Stokes-Adams syndrome. It is also called as AV dissociation. It is also called as a third degree heart block. So great. Moving to the next question, which has again been asked. This time, this is again an FMG exam question. And after the paper, when we had this discussion, everybody was like, somebody was saying, boss, it was bradycardia based question. And there were some people who were saying, no, boss, it was a tachycardia based question. So what you have to select here is, yes, quick comments in the chat box. There's a Brady component also present, and there's a tachy component also present. So we are going to call it a variant of sick sinus syndrome. This is called as bradycardia tachycardia syndrome. This is a bradycardia tachycardia syndrome, where in a single patient, first the SN node will forget to fire, so there would be a brady, and then SN node is saying, oh man, I forgot to fire, so it's trying to work more, and therefore there would be a tachy component present here. You would not say the word sick sinus syndrome, because there would be absent P waves present. In this, somewhere I can say I can pick up a couple of P waves present, so I'll call it a variant of sick sinus, that is called as a bradycardia tachycardia, where, like, you get a combination of the two findings, and that's a compensatory thing that's happening in the patient. Okay, so this was like 14 ECGs that I've discussed before you, the core ones. I've not tried to make it difficult. I try to keep it lucid, simple, straightforward, scroll through like 10, 14 minutes, and you're through with the common kinds of ECGs there. And now we move on to the next question, which is again a very simple one. But instead of simply telling you the X-ray evidence, what I want to do is I want you to critically analyze it. So Romanov ward is basically a defect related to the potassium channels. Now it's a repolarization defect, so it causes a QT prolongation, and because of this QT prolongation, a arrhythmia can occur, that is Torsades pointer, so it can cause sudden death in a patient. You talked about Romanov ward. So Romanov ward and Jervell-Lange-Nielsen syndrome, they're basically potassium channel defects. Like we talk about channelopathies, no? Meanwhile, people are answering. I'll just answer this gentleman who put up, just like you are comfortable with the fact that Brugada syndrome is a sodium channel defect. In a similar sense, when it comes to Romanov ward or when it comes to Jervell-Lange-Nielsen, it would be a potassium channel defect. So these are like, and the problem with this potassium channel defect is a QT prolongation. And whenever there's a QT prolongation, it predisposes to Torsades pointers in a patient. So these can contribute to sudden death. And therefore, if you get a positive family history, implantable cardioverter defibrillator would be required. Okay, so I'm getting a B in this question. Read the question carefully, guys. Not every question is that of pneumothorax. भाई ध्यान से पढ़ो. Trauma patient is having breathing difficulty and a dropping auscultation shows dull percussion. Pneumothorax में क्या dull percussion होगा क्या? Pneumothorax में तो hyper resonant percussion होता है ना? It is a hyper resonant percussion. और इधर तो कहाँ पे है भाई? आप देखो ना, यहाँ पे तो CP angle जो है उसका blunt हो रहा है. So this guy is having a hemothorax. जरूरी थोड़ी ना है कि every time a guy is having a trauma to the chest, it will result in a pneumothorax. The guy is having a hemothorax occurring. That is why the blunting of the claustrophrenic angle is occurring in this patient, and even the auscultation is showing like presence of distant breath sounds because there is blood covering it. So what we need to do is we need to take care of this blood. Yes, guys, more comments now. Yes, hit the comment box, man. I would like everybody to be very, very particular about this. कि अगर ये हेमोथोरैक्स का सवाल है तो हम क्या करेंगे, चेस्ट ट्यूब डाल देंगे, ब्लड निकल जाएगा ना. सो चेस्ट ट्यूब इन द फिफ्थ इंटरकॉस्टल स्पेस इन द ट्रायंगल ऑफ सेफ्टी would be required. Learning point is, and they did this in last time's exam also, that they give you a question on a trauma and everybody is thinking pneumothorax. It is not a tension pneumothorax. If it was tension pneumothorax, there have to be pointers given in a question, right? For tension pneumothorax, you need to have information given, hyperresonant percussion note. You have to have information of absent air entry, absent breath sounds. Then there could be subcutaneous emphysema, crepitus under the skin, X-ray evidence. I mean, you can see the lung markings. No, you can see the lung markings in this case. Okay, I'm using black, so would not be visible. Okay. So you can see the lung markings, man. You can see the lung markings here adjacent to the cardiac border. So there would be no lung markings when it comes to a pneumothorax. So मनी बैग वो बच्चे इसलिए ना क्योंकि AP व्यू है ना. Why this X-ray is looking like a money bag appearance is because it is a AP view. So in AP view, the heart can look relatively bigger, na. So size of the heart is not to be commented in a AP view, and the film is rotated also. No, you can see it's like patient is lying in the stretcher a little oblique. So you need to be a little careful about it. So I think Tejas, don't worry, man. You getting some correct and some wrong, so it's a part of the game. Learning point for you guys is सीधा मत बोल देना कि वाइट बोर्ड नेटल डालेंगे. एक्सरे करते हैं पहले. You need X-ray evidence, right? बिना X-ray evidence के तो you can't be sure. And then subsequently you put a white bore needle for a tension pneumothorax, fifth intercostal space, never an issue. This question was not on tension pneumothorax, guys. It is a hemothorax here. And why not a pleural effusion? Because trauma is given in the question, no? So trauma patient would be छाती पे मारा यार किसी ने, दो चार लोगों ने घूसे मारे है ना, या कंस्ट्रक्शन वर्क करता सीढ़ी से गिर गया तो छाती के बल गिरा तो यार ब्लीडिंग हो जाएगी ना. तो दैट विल कंट्रीब्यूट. आई मीन इफ देयर इज अ ट्रॉमा गिवन इन अ क्वेश्चन देन इट कुड बी ब्लड ओनली ना. And that is why, yeah, absolutely, that makes it confusing. X-ray काला ही होता है है ना. X-ray तो काला ही होता है. So it is like there's no pneumothorax present here, guys. This would be a chest tube in the fifth intercostal space. Okay, fine. Moving ahead in this patient, moving ahead in a question, I'm gonna give you one more case on trauma. This time this bacha was playing on the swings and he fell down, and then you can notice these multiple fractures of the ribs at multiple places. So there is paradoxical breathing also given, because normal breathing is thoraco-abdominal, but in this case there is a abdominothoracic breathing. So this is a case of a flail chest, and the question will say that our patient with flail chest will be predisposed to development of which of the following. Yes, guys, quickly answers. Okay, I'm waiting. Hit the comment box, man. Next 15 seconds I'm gonna give you so that you can hit the comment box. Flail chest occurring in a patient would contribute to development of a pulmonary contusion. भाई जब रिब्स टूट जाएंगे तो वो लंग्स को डैमेज कर देंगे, पल्मरी कंट्यूजन करते हैं. एंड पल्मरी कंट्यूजन इज अ रिस्क फैक्टर फॉर डेवलपमेंट ऑफ ARDS, दैट इज एक्यूट रेस्पिरेटरी डिस्ट्रेस सिंड्रोम. बच्चे फैट एम्बोलिज्म के लिए तो द क्वेश्चन शुड बी मेंशन रिगार्डिंग फ्रैक्चर ऑफ द लॉन्ग बोन्स. Apart from fracture of the long bones, like apart from the femur fracture, shaft of the femur fracture, the question should also mention regarding some kind of GERD criteria. Though I'll make you revise the GERD criteria next 15 seconds. GERD criteria means that there should be mention of drop in oxygen saturation with the X-ray turning to be having bilateral infiltrates. There should be a coma in a patient. There should be fat. There should be evidence of petechiae in the axil of the patient, and then this petechiae will go and they will be involving the chest wall of the patient as well. So this is not fat embolism. And when it comes to venous air embolism, neurosurgery is where we usually get this venous air embolism. In neurosurgery, the dural venous sinuses are injured. That is where venous air embolism can be seen. And pulmonary embolism जो बोले बच्चे, that is seen with deep vein thrombosis ना. यहाँ पे तो DVT तो नहीं होगा ना, like he is having a fall and then there's a paradoxical breathing. So pulmonary contusion is the bleed that can contribute to development of acute respiratory distress syndrome. If you listen to the discussion of ARDS, I've said like this: sepsis, pneumonia. In fact, first is pneumonia, then is sepsis. I should have asked you this, but anyway, the number one cause of ARDS is pneumonia. After pneumonia, the next cause was sepsis. Then comes pulmonary contusion. That could be trauma to the chest, which could contribute to this. And that is why in one lung already the white infiltrates are coming in this guy. So when you read about the causes of ARDS right in front of you, there would be toxic gas inhalation, like the worst industrial disaster in the world. That is Bhopal gas tragedy occurred and people died because of ARDS. Before I finish this question and move on to the next one, what I will also do is mention regarding the Berlin's criteria. Though that criteria word is outdated, but I'll just say it. Berlin's criteria for diagnosis of this condition. Berlin's criteria should be that PaO2 FiO2 ratio. Guys, वही तो practice करा रहा हूँ. The question is not a direct question. It is an analysis of the image. So, you know, अगर इतना ही आसान होता तो we would have never talked about it. So, Berlin's criteria is PaO2, FiO2 value less than 300. That is why my request is please use custom modules. And I am having a live test and discussion like this on 21st as well. I'll be discussing all the questions of all the subjects. This would be on 21st from 12 o'clock onwards, the entire like 6-7 hours of data. So I want you to sit with me and practice all those questions. Or abhi aap, you can go to the app and you can start giving. I mean, after we are done with this, I would like you to dedicate at least 2-2.5 घंटे बैठ के seriously paper देना. जल्दी जल्दी पेपर नहीं करना है. मोस्ट ऑफ यू नो यू गेट डन विद द पेपर वेरी फास्ट, ही खत्म करो. एंड इन द एग्जाम सम पीपल आर नॉट एबल टू इवन कंप्लीट द पेपर, दो दे कंप्लीट इन द ऐप विद इन 1 hour, 1.5 hour, they don't even are not able to complete in the actual one. So don't rush through it, sit on a laptop, give the question paper, and invest time on this. And then on 21st I'm gonna be doing this mock practice with you. Okay, so PaO2 FR2 ratio would be less than which test is it? If you go through now, the last wala jo test hai abhi wala, that is the one that is being conducted in the PrepLadder. Yep. नीट सारे दोगे ना यार, FMG वाले भी देने, नीट पीजी वाले भी देने. Same for नीट पीजी guys, you have to give FMG exams also, because that more you practice, man, more you practice, it will make you much more confident. Okay, so okay. PO2 FiO2 ratio. Type 1 respiratory failure, no, you have to check Navjyoti again. It is described as type 1 respiratory failure. It is like when patient will deteriorate. जब इसको ventilator नहीं मिलेगा तो they go into type 2 ना. यही तो होता है ना रेस्पिरेटरी में. क्या होता है कि जैसे टाइप 1 फेलियर में पेशेंट आया, अब उसको वेंटिलेटर चाहिए, अब वेंटिलेटर इज नॉट अवेलेबल, देन पेशेंट विल गो इनटू रेस्पिरेटरी मसल फटीग, दैट विल कॉज टाइप 2. एंड लाइक कोविड में भी तो यही हो रहा था. कोविड वाज कॉजिंग ARDS, पीपल यूज्ड टू कम इन टाइप 1 एंड डाई ड्यू टू टाइप 2 रेस्पिरेटरी फेलियर. तो दोनों होते हैं. नाउ व्हाट टू आंसर इन द पेपर इज लिसन टू द रेस्पिरेटरी फेलियर वीडियो. आई हैव डिस्क्राइब्ड एज टाइप 1 फेलियर ऑलरेडी. ओके जी, मूविंग अहेड. सो सबसे पहले तो PO2 FiO2 रेशो होता है. And then is the second aspect, that the X-ray of the patient should be showing bilateral infiltrates, and these bilateral infiltrates should be developing within 1 week of the insert. Like अगर अभी चोट लगा उसको तो within 1 week के bilateral infiltrates बढ़ जाते हैं. और the third feature would be a echocardiographic finding that the left atria of the patient is normal. I mean there's no cardiogenic pulmonary edema, because ARDS is an example of, मेरी सबसे important line of this particular MCQ is ARDS is an example of non-cardiogenic. ARDS is an example of non-cardiogenic pulmonary edema. So step 1 is to understand that this is gonna be non-cardiogenic pulmonary edema. एंड बिस्फेरियंस एंड डाइक्रोटिक. बिस्फेरियंस में 2 पीक सिस्टोल में होती है, और डाइक्रोटिक में 2 पीक सिस्टोल और डायस्टोल दोनों में होती है ना. डाइक्रोटिक पल्स होती है सिस्टोल में भी पीक, डायस्टोल में भी पीक. डायलेटेड कार्डियोमायोपैथी. बिस्फेरियंस होता है हाइपरट्रॉफिक में, उसमें पीक वुड बी सीन इन सिस्टोल एज वेल एज two peaks in systole only. So I think Damru, I answered your query, and I think I did address you at NNL also. Okay, so I think we are sorted for this one, guys. The answer to this question is option number A. तो अगली बार जब फ्लेल चेस्ट पे सवाल आएगा तो गलत नहीं करना. और ट्रॉमा का जो सवाल है एनालाइज करना है. हेमोथोरैक्स है, न्यूमोथोरैक्स है, दोनों है, दोनों भी हो सकते हैं, राइट. ओके. Lung injury, they can't be pneumothorax only. Hemo, no, they can be pneumothorax also. But then Suvarna, we have to pick up on the clinical findings now. Like the question is mentioning that there is reduced air entry and there is dullness to percussion. That means there would be blood present. If it was hyperresonant, then it is pneumothorax. So you have to analyze it properly. Okay, so Damru, for you, I'm drawing that image of 2 peaks in systole and 1 peak in systole and diastole respectively. Meanwhile, the remaining guys can continue to comment on question number 17. This is the dichrotic pulse. ये systole है और ये diastole है. तो systole और diastole दोनों में peak आ रही होती है. और जो Bispherians pulse होती है, in Bispherians pulse, the peak would be coming, 2 peaks would be coming like this in the phase of systole only. अभी अलग अलग नाम रखा गया. S मतलब systole है, D मतलब diastole है. जो बिस्फेरेंस वाली पल्स होती है हाइपरट्रॉफिक कार्डियोमायोपैथी में, और डाइक्रोटिक वाली जो पल्स होती है दैट वुड बी सीन फॉर डायलेटेड कार्डियोमायोपैथी. ट्वाइस बीटिंग पल्स इन सिस्टोल प्लस डायस्टोल, एंड दिस वुड बी हाइपरट्रॉफिक फॉर बिस्फेरियंस. चलो जी, मूविंग अहेड इन आवर डिस्कशन. वेरी गुड. Patient starts having shortness of breath and drop in saturation while on the ventilator. He says, which of the following is the likely diagnosis? Yes, very good. I'm getting A as an answer predominantly. I'm getting B as an answer also. So बच्चे barotrauma will contribute to pneumothorax. If it is barotrauma, it will contribute to development of tension pneumothorax in a patient. और अगर ये pneumothorax होगा तो फिर तो एक्सरे काला हो जाएगा ना. Then the X-ray will become black. But check out the X-ray. The X-ray of the patient is totally white. So it cannot be barotrauma. It cannot be pneumothorax. Yes, now you guys are getting a hang of it. Straight away ट्रॉमा पढ़ के भाई न्यूमो से बाहर निकलो यार. ऐसे ही बता रहे हैं कि भाई एक्सरे दे रखा है, ट्रॉमा लिखा है तो न्यूमोथोरैक्स का क्वेश्चन है. दैट इज नॉट द राइट अप्रोच बच्चे. आई एम ट्राइंग टू गिव यू द राइट कोर्स ऑफ डायरेक्शन. ऐसे नहीं सोचना है कि भाई एक्सरे दिया तो मतलब न्यूमोथोरैक्स का ही सवाल है, सीधा वाइड बोर नीडल डाल दिया, ऐसे नहीं करो. What you have to pick up here is the X-ray is white because this is air is black and obviously the X-ray is totally white. So the guy is going into acute respiratory distress syndrome. He is on a ventilator ना. Pneumonia can worsen. जब कहते नहीं कई बार पेशेंट को कि जी इनका निमोनिया बिगड़ गया, say that in हिंदी, क्या हम बोलते हैं कि जी इनका निमोनिया बिगड़ गया. एंड फैमिली मेंबर्स लाइक क्या मतलब निमोनिया बिगड़ गया, तो निमोनिया बिगड़ गया मतलब दैट इज लाइक पर्सन इज गोइंग इनटू acute respiratory distress syndrome in a patient. Yeah, Kaushal, you are perfectly right. We need to sometimes my job is to get you in the right direction. So yep, it is ARDS in this question, guys. MODS is multi-organ dysfunction, बच्चे. MODS is multi-organ dysfunction. चलो अब आपने पूछा ही तो मेंशन करो कितने से ज्यादा ऑर्गन का फेलियर अगर हो जाए, इतने से ज्यादा ऑर्गन्स का फेलियर हो जाए कि जैसे सेप्सिस हुआ पेशेंट को, तो मल्टी ऑर्गन डिस्फंक्शन. व्हेनेवर यू से मल्टी ऑर्गन डिस्फंक्शन, मोर देन हाउ मेनी ऑर्गन्स डिस्फंक्शन वुड बी occurring. Slightly controversial, but yeah, I think a pretty decent one. At least two or more than two organ malfunction if occurring in a patient would be called as MODS. Some books mention one also, but yeah, at least two is fine enough. Like heart is affected and the kidneys are also affected. No, lots of time like person has a cardiac failure and then there's a renal shutdown in a patient also. Like patient had cardiogenic shock and went into renal failure. Finally, what is the take home message from here? The take home message is ARDS causes should be very, very clear to you. ARDS can be a complication of pneumonia. It can be a complication related to sepsis. Then it is seen with transfusion. That can be transfusion related acute lung injury. Then the next cause is trauma to the chest. That could be pulmonary contusion. Then is acute pancreatitis. Those guys who are listening to me for NEET PG exam, I think you would be familiar. I think it was in last NEET PG or prior to last NEET PG. They had given a case of a guy alcoholic with acute pancreatitis. Or enzyme values were very high. He was having epigastric pain going to the back, and then he was having breathing trouble. And the X-ray was given to be like this. He said, what is the complication that has occurred in this? Even in acute pancreatitis, because of release of the enzymes into the circulation, there is damage to the lung circulation, which causes acute respiratory distress syndrome. Must know causes that I'm discussing before you at this moment are causes of ARDS, which is a neglected answer in the question. Everybody thinks in terms of pneumothorax only, and in a lot of questions it is ARDS as the answer as well. And one more cause of ARDS that I would like to mention, I mean, I've talked about pancreatitis, toxic gas inhalation, pulmonary contusion, trolley, pneumonia, sepsis. Obviously pneumonia is one of the most common one. Is development of aspiration pneumonia, that is I can write that as chemical pneumonitis or Mendelssohn syndrome. This guy, he is having aspiration pneumonia while during intubation, and that can contribute to again acute respiratory distress syndrome in a patient. So I think we had a very nice discussion with respect to the X-rays part at the moment, and I'm trying to make your brains think a little more than what is I mean, make your brains, your brains are very sharp, what I'm trying to do is fine tune the thought process so that you're able to analyze every exigency. So after my wordings, like be a little more careful while attending these questions. Yes. FeV1 FVC रेशो नहीं दिया तो डिफरेंस कैसे होगा किसमें? FeV1 FVC रेशो आपको क्यों चाहिए? FeV1 FVC रेशो क्यों चाहिए होगा for differences between these? FeV1 is for obstructive and restrictive lung disease, ना? Okay जी, so I'll just mention regarding type 1 respiratory failure and type 2. Type 1 respiratory failure is where the person is having hypoxia और तेज तेज सांस लेगा, तो PCO2 the patient can be less or normal. The best examples of this are acute respiratory distress syndrome and fat embolism syndrome. That is type 1 respiratory failure. The best examples of type 2 respiratory failure where there is a hypoxia obviously present, and there is an increase in the partial pressure of carbon dioxide, there would be carbon dioxide narcosis. The best examples of this are two. One is acute exacerbation of COPD, and the second one after acute exacerbation of COPD would be status asthmaticus. That would be also a impending respiratory failure. So just a familiarity with type 1 and type 2 failure. Okay, so let's look at what comments are you making for the next one. A patient is admitted with a subcutaneous swelling on the chest. There's a high grade fever. He's being treated for a lung infection, which is a pneumonia. And the pneumonia, which you can see here, has resulted in a parapneumonic effusion. The white thing that you can see here is that there is a effusion developing in this guy. It is biconvex, na? This biconvex is the pus which is accumulating in the pleural space of the patient, and then it is eroding into the subcutaneous tissues as well. So the correct answer in this particular case would be empyema thoracis, for which again a chest tube would be required in the patient subsequently. Yes, pus breaks through the pleura, absolutely. And this biconvex presentation that is given in this question points towards the diagnosis of this question as empyema thoracis. So great, guys. I mean, good that you're able to pick this up. This is not a lung abscess because there is no air fluid. I mean, there's no air fluid level that is given. Bronchiectasis will be having those dilated, destroyed airways, so not present. And cold abscess, then cold abscess would be last thing on my possibility in somebody with a high grade fever with chills and rigors. I mean, cold abscess does not present with like high grade fever with chills and rigors. So we need to first and foremost is the chest tube, right? And then we need to give respiratory fluoroquinolones to this guy because this would be fairly a sick patient. So moxifloxacin would be required. Along with this, we'll give coverage for staph aureus and we'll give coverage for even pseudomonas in the patient. So it would be at least respiratory fluoroquinolones with vancomycin or linezolid. So I can say moxifloxacin with linezolid, and if required, then we might be giving coverage with meropenem as well. But culture reports would be present there. Okay, so the main aspect is that there is a subcutaneous swelling in the tuberculosis. Yeah, I mean, that's what I'm trying to say. TB would be unlikely to present with like a high grade fever with chills and rigors in this case. And there is this basically is a parapneumonic effusion that is occurring. So we may not be able to see that classical split pleura, but there's a pneumonia patch in the periphery, and then there's a pus that is breaking through the tissue. So the diagnosis in this case can be option number C. No, this would not be a subcutaneous emphysema. It's a empyema. No, empyema would mean that there would be a pus in the pleural cavity. This is not obviously an emphysema. So I think that is pretty clarified. So moving to the next one, spot diagnosis. In this case, you guys can help me out. Yes, guys. Chest tube and antibiotics. Without chest tube, empyema can't be treated, right? Okay, very good, very good. So that's what I'm trying to say. No, there is a blunting of the costophrenic angle, and the appearance is totally wide. But no, guys. This is again having a convexity. No, in a pleural effusion, this area would be concave. There would be a meniscus sign present. In this case, there is no concavity present. It is a convexity. I'll just try to draw this for a pleural effusion. I'll show you a subsequent X-ray also. But before I do that, I just want to bring to your attention that if it is a pleural effusion, then the area will be concave in upward direction. If it is a concavity present, then it is a pleural effusion. If it is a convexity, then it would be going in favor of empyema. Like we always read about meniscus sign, we always read about a concavity. So if this question was having that classical Ellis curve, if this question was having that classical meniscus sign, then never an issue. I would have answered this as option number A. But considering that there's a convexity present, though I mean ideally you should mention a history as well, but because today we are discussing on questions, I just want to bring to your attention that if it's a convex thing present here, then we'll go for option number B in this case, that is empyema. And hemopneumothorax, how will it present? That also I can quickly sketch here. For hemopneumothorax, obviously the area will be wide, but then the upper part of that would be straight line. So I can draw option number C in this question as well, as you can see in this representation. Yes, so if this is a straight line, then option number C would be the answer. If it is concavity, then option number A is the answer. ARDS X-ray, I've already shown you bilateral infiltrates present with a normal cardiac function. I mean, we have to ensure that we document that that would be a non-cardiogenic pulmonary edema for acute respiratory distress syndrome. Trachea position would not be significantly affected, and even if it is difficult to pick up in an AP view. So whether it is a pleural effusion or empyema, trachea will always go to the other side. It is just that in an AP view, the position of the trachea is not suitable for diagnosis. Okay. Okay, so moving to the next one, which of the following is correct about the X-ray that is shown? So let's have answers here. Yeah, yes, Nasser, you're right. Hemopneumothorax and hydro means it can be blood also. No? Hydro means it could be water or it could be blood present. So I'm gonna show you the options, and now I'm zooming into the images a little more so that you can think of the diagnosis. First investigation for pleural effusion would always be an ultrasound, and ultrasound is one that is preferred. I mean, if they ask you sensitivity, then obviously CT scan is more sensitive than an ultrasound. But initially, we do an ultrasound. Investigation of choice is ultrasound also. Okay, very good. So the first diagnosis or the first image that is given here, you can see a lobar pneumonia, which is occurring in this case. Like because of lobar pneumonia, it would be bronchial breathing. And then you can see a pleural effusion because there is a meniscus sign which is present in this case. So stenoidal percussion note is present. And then the third one you can pick up is this is the pneumothorax that I'm talking about, where you get a hypertransluent lung with absent lung markings. And in this case, there would be a contralateral mediastinal shift. Like you can see that the heart is getting pushed to the contralateral side. So the correct answer for this one is now picked up very well by everybody as option number C. The main thing you have to pick up was three questions. One is consolidation, pneumonia. The second one is a pleural effusion. And the third one is for a pneumothorax. And I'll just zoom it in so that you can compare the two lung fields as well, so that you can pick up the pneumothorax and you can pick up the mediastinal shift as well. So the correct answer for this question would be option number C. हाइपर रेजोनेंट न्यूमोथोरैक्स में होगा ना, हाइपर रेजोनेंट परकशन नोड न्यूमोथोरैक्स में होता है, डल जो होता है वो निमोनिया में होता है, स्टोनी डल जो होता है वो प्लूरल एफ्यूजन में होता है। मैं लिख देता हूँ यहाँ, निमोनिया के केस में डल होगा, प्लूरल एफ्यूजन के केस में जो परकशन नोट होता है वो स्टोनी डल होता है। And whenever we will talk about a pneumothorax, then it would be a in our chest, in you and me, it is resonant, and in this case, it will turn out to be a hyperresonant node. So I think we are sorted for these three questions. Yes. Absent air entry. Absent air entry. If it's a partial damage, then you may not have an absent air entry. No, in a pneumothorax also, it can be distant breath sounds also. Okay. Keywords for pneumothorax is absent air entry, absent breath sounds. The moment you read absent air entry, absent breath sounds with hyperresonant percussion note, तीन चीजें होनी चाहिए pneumothorax के लिए। टेंशन वर्ड तब बोलते हैं जब बीपी क्रैश हो जाता है। You say the word tension when it is the unrecordable blood pressure. So even if in a case BP value is given to be stable, your answer of wide bore needle will anyway not be valid. I mean, when you say the word tension is, it should be causing a hemodynamic instability, because that's an example of obstructive shock. Then if the question says absent air entry, he says absent breath sounds, and he talks about hyperresonant percussion, that is when I'll be thinking in terms of a pneumothorax in a patient, and my words would be tension pneumothorax. Only in that circumstances would I be answering it as a wide bore needle followed by a chest tube in the triangle of safety. Otherwise I won't be, so you need to check out the blood pressure values in the question as well. Okay. Okay, fine. Let's move on to the next one. The right lung in the second image also has absent lung markings. No, doc, but the lower part of the lung field is still having those lung markings very nicely present. Even in the mediastinum, the lung markings, I'll mark them out before you. Even you can see the lung markings here, you can see the lung markings here. So to say, even in the upper part also, I can see the lung markings. So to say that would be a little, I would say, far-fetched. And it's more pronounced on the third X-ray. Okay. Okay. So, doc, you can congrats on completing your orthopedics already, but good that you joined here, and these guys can take motivation from you. So let's move on to the next one. Anyway, good to hear from you. One of my ex-students here, guys, he's an orthopedician at the moment, third year, and can try and ping him if possible on YouTube for any other guidance. Okay. Which valvular lesion is likely to be present in this case with a breathing difficulty? So the key word in this question, or the key feature, would be straightening of the left heart border. The straightening of the left heart border is a feature that is always seen in mitral stenosis. I mean, the key finding in this X-ray is that left atria का enlargement हो रहा है, left atrial appendage का भी enlargement हो रहा है. So straightening of the left heart border is always a feature that is seen with respect to mitral stenosis. And considering that, what you get in these patients would be a diastolic murmur. The correct answer for the 21st image-based question in this particular series would be option number A. Let me just check how many people have got this one right. Okay, Ronak has a good input. Pulmonary artery hypertension would also come up in this case. Yep. But Considering pH also, it will ultimately cause pulmonic regurgitation and a diastolic murmur only. So good one. I think you guys are good at picking that up, that the left atrial appendage is enlarged in this case. And 18-year-old would have also made it easier for you. So let's move on to the next one. With chamber enlargement is shown in the X-ray of this patient, that would be used. Okay, so Mehra, I'll just write down the severity of this. I think this was an FMG exam question like last time. I've discussed in the recall session, but anyway, severity of mitral stenosis is inversely related to S2 and opening snap gap. There's an inverse relation. This was the basis of the question that was asked in FMG last time. The distance between the S2 and the opening snap becomes lesser as the severity of mitral stenosis will become relatively much more severe because the duration of the murmur will increase. Yes, this would be a boot-shaped heart. So boot-shaped heart would mean that the apex of the heart is uplifted. So this would mean that the right ventricle of the patient is relatively enlarged. So the correct answer in this case would be the right ventricle. Yes. So, yep. Is the length of the murmur? Yeah, I mean the technical both mean the same only. Now, whether I say the word length of the murmur, whether I say as to opening snap gap, both of them would basically mean the same. Okay. So every time they give an X-ray in which the apex of the heart is lifted up, it would indicate that there's a right ventricular enlargement. But if you notice an increased cardiothoracic ratio with this convex boundary that you can see, then this is suggestive of a left ventricular enlargement. So you just have to check up the upliftment of the heart that is occurring. Somebody mentioned about the split, but only two things to be remembered. If he says narrow split second heart sound in any question, you always have to think in terms of left ventricle failure or obstruction in the left side of the heart. But whenever a question talks about a wide split or second heart sound, you always have to think in terms of right ventricular failure in a patient. Just get this much data right, you are sorted for the splits instead of going into the splits, the entire thing again. Okay. Moving to the next one. This asthmatic patient, again, they love to ask this, especially NEET PG also, they've asked about it. In fact, it was two-step, they asked treatment, so you can comment about that also. This is an asthmatic and he's having tenacious sputum plugs and a cough. The HRCT was done. And then you can notice these dilated airways. There's a damage to the airways. In fact, the thickened wall is present. So this would be allergic bronchopulmonary aspergilloma. One of the highlights of this condition is central bronchiectasis. The moment you read this word, your interpretation is we are dealing with ABPA, that is allergic bronchopulmonary aspergilloma, which is caused by aspergillus. The comments have come up right beautifully. Correct answer is A. And you guys can quickly comment on the treatment for this condition as well. I mean, this is a hypersensitivity reaction to Aspergillus fumigatus. And therefore, what would you be doing for management of this patient? Yes, guys, quick answers with respect to the treatment. No. That is the point. This is not invasive aspergilloma. This is not invasive aspergilloma. This was the question in NEET PG. They gave up a question on allergic bronchopulmonary aspergilloma, and most guys answered it as voriconazole. This Aspergillus fumigatus causing ABPA is a hypersensitivity reaction to the fungus. So all we need to do in this asthmatic patient is इस asthmatic को हम voriconazole नहीं देंगे. We will be giving steroids to this patient with itraconazole. So the trick in the question was that voriconazole was right on the top. It is steroids and itraconazole that are used for management of allergic bronchopulmonary aspergilloma. Suppose this question was mentioning regarding a person with a tubercular cavity. Suppose we were having a question on a patient with tubercular cavity, and then he mentioned that the HRCT chest of the patient shows a cavity with a fungal ball. Like he says, fungal ball in a cavity which is caused by tuberculosis. You know, aspergillus can be angioinvasive, especially aspergillus niger. And in those circumstances, because here there would be hemoptysis, no? Because invasive aspergillosis, there would be presentation of hemoptysis. Here is not having hemoptysis. It is tenacious sputum plugs and a cough present in the patient. So if I say a person who's having a pre-existing tubercular cavity is having a fungal ball present and there is a hemoptysis occurring, that is when we have to think in terms of voriconazole for the patient. So again, a suggestion to you. If you had problems answering this question, my suggestion is that if you go into the medicine section in the PrepLadder app, in the last I've discussed infections. All these aspergillus I've discussed, pneumocystis. I know you've read them from microbiology, but it will make it more confident. Just they're 15-minute videos. I'm not talking about the HIV part. I'm talking about the subsequent ones, very short ones, very crisp ones. Just rush through them fast. The main ones. They'll revise your medicine. They'll revise your drugs. They will revise your pathology as well. So I mean, if you listen to that, these things will become much more clear to you. As somebody mentioned very rightly, that is Rosenbach criteria for ABPA is a totally different ball game which has to be remembered. So there are two different aspects. Somebody commented, sir नीट पीजी वाला भाई नीट पीजी में यही पूछा वो कि उसने सिनेरियो दे दिया एस्थमेटिक का, उसको टेनिशियस कफ था, उसको स्पूटम प्लग्स थे, और वहां पे हम उसको वोरिकोनाजोल यूज नहीं कर रहे हैं. वी आर गिविंग स्टेरॉइड्स विद इट्राकोनाजोल फॉर द पेशेंट बिकॉज दैट्स लाइक अ कॉलोनाइजेशन ऑफ द एयरवेज बाय एस्परजिलस फ्यूमिगेटस. तो एक बारी इसको जरूर देख लेना. दैट इज invasive aspergillosis versus ABPA. Both are two separate manifestations that are occurring with aspergillus only. Both are caused by aspergillus only, but allergic bronchopulmonary aspergilloma, the scenario will be given of asthmatic. And in cases of invasive aspergilloma, it would be a pre-existing cavity caused by, let me say, TB, and then there is the angioinvasiveness, which can cause development of a hemoptysis in a patient. So those technical differences are the ones which are to be remembered for allergic bronchopulmonary aspergilloma versus invasive aspergilloma. Okay, RT-Pix. Yes, Sharath Reddy. I mean, you picked up exactly from the notes that mnemonic is also given. But yeah, I mean, even if you don't get the mnemonic right, I wanted to be very, very clear about central bronchiectasis of ABPA versus the cavity with hemoptysis of the angioinvasiveness that can contribute to requirement for voriconazole. So I think we sorted for 23. This again is a high yield question. If you have any issues, request is check out aspergillus in the inferior part, last in the right in the end, the infections part. It would cover your medicine, it will cover your pathology, it will cover your microbiology segment, and obviously overall holistic view. Just 15 minutes of your time. If you listen at 2x or 1.5, then maybe I mean, it will take a little bit or more. Okay, moving ahead. So we have this patient who underwent a TKR, a total knee replacement. And in this patient with a total knee replacement, there was shortness of breath, and you can see the flood of comments that are coming. Hit the comment button, guys. Hit the comment button. There is a total knee replacement that is being done in a patient. The oxygen saturation of the patient has dropped, and there's a hypotension which is occurring in this guy. This is a huge clot. It's like a saddle embolus. You can see a huge clot. It's a saddle embolus which is sitting at the bifurcation of the pulmonary artery. So the manifestation in this particular case would be that of a massive pulmonary embolism. And if you are having a massive pulmonary embolism, you need to use a clot buster. I think everybody got it spot on. This would be enoxaparin, and enoxaparin will be giving L-Teplis in a patient since the blood pressure in the patient is low. In case in this question, the blood pressure values were given to be more than 90/60, I would have managed only with the low molecular weight heparin. I would not have been using a clot busting drug. But in a scenario of every time there's a hypotension, I mean, how do I say the word massive? Is obviously one from the image. You can see the bifurcation of the pulmonary artery. You can check out the ascending aorta. You can check out the descending aorta, and then you can see this is the pulmonary artery. It's bifurcating into two, and you have this huge saddle embolus sitting at the bifurcation because there would be, and there's a history also given, no? Because patient is undergoing a joint replacement surgery. So if somebody undergoes a joint replacement surgery, orthopedic procedure, it does not mean fat embolism. If somebody is undergoing a knee replacement surgery, it does not mean a fat embolism. When you are talking about total knee replacement after TKR, person can be immobilized. I mean, patient, though the surgeon might encourage the patient to walk, patient may not walk, and therefore deep vein thrombosis risk is increased. That is why physiotherapy is important. That is why pneumatic compression stockings are important. And we also give post-operative enoxaparin after surgery to high-risk patients to decrease the incidence of whatever that happened in this particular question. I've also explained that the tennis player Serena Williams, she has suffered from pulmonary embolism, and luckily, I mean, after a delivery, she was having this calf pain which was neglected by a gynec, and then the clot went to the heart. It caused a massive PE, and luckily, I mean, she was diagnosed and was treated. Otherwise, like this tennis player, I mean, the Grand Slam champion Serena Williams, she might have had a fatal outcome as well. Okay, so S1Q3T3, McConnell sign, absolutely good ones, good points which are coming up here. Great. Okay, guys, so moving up to the next one, clot buster medicine was given. And we have another patient with fever and breathing difficulty, and then the X-ray is shown there. Well score would help you out. हाँ, यही तो बात है ना बच्चे, यही तो सिखा रहा हूँ कि फैट अबॉलिज्म नहीं सोचना ना। फैट अबॉलिज्म के लिए GERD क्राइटेरिया होते हैं। मैंने पहले भी बोला था, I'll say that again, GERD criteria would be having lung issues, brain issues, coma, decreasing GCS, and petechiae in the axilla and in the chest wall. Unless and until they're not given the GERD criteria, don't think in terms of fat embolism in a patient. Yes, what you can check out in this case is a bulging fissure sign. I think the radiologist talks about it. I'm talking about it. So this is again a very classical bulging fissure sign, and sometimes in question he might mention regarding alcoholic as well. So I had the correct answer there. That would be Klebsiella pneumoniae, where that characteristic red currant jelly sputum can be present in a patient. And most of the time, the question might be mentioning regarding the hint of alcoholism as well. I mean, every time he mentions alcoholism in a pneumonia patient, it is Klebsiella pneumoniae, which is to be considered. Okay. This is specifically for, okay, I'll not categorize. Yes, guys, quickly comment between the two. Obviously, we can see this Silhouette sign. We can see these air bronchograms. And obviously, it's a right side, but you have to comment regarding the right middle versus the right lower zone. So, yes, guys, quickly comment here whether it is right middle. Yes, because you have to see the lateral view here, and the lateral view में जो patch है वो आगे की तरफ present है, anteriorly present है. So this would be a right middle zone pneumonia. One, you can notice that there is a Silhouette sign present in this guy. You can see these air bronchograms present adjacent to the cardiac shadow. So characteristic Silhouette sign. And then what you can check out is that the shadow is present much more, aligned with the middle lobe of the patient. So this would be RMZ, that is the right middle zone pneumonia. And usually they give up this question on RMZ and write lower lobe pneumonia. For lower lobe pneumonia, you'll always notice that the shadow will be present much more posteriorly. So I've given two of these images, and obviously this PDF, there are two ways to access it. One is in the description of this video only. This PDF will be pinned, and you can just download from there as well, or it would be present subsequently available in the app as well, or you can drop me a mail at marvamedicine@gmail, and it can be accessible. I think easier to check out it out in the description of the video. So I think we are sorted for this one, a good answer for 26, and you've done your radiology class well. Okay, so this time we're putting two images. Moving to the next part of our discussion, we have this lady. She's having a stridor with a breathing difficulty for past 3 months. And stridor, inspiratory stridor is always a cause of concern that there's something pressing on the large airways. And then there are lesions on the shin of this lady as well. You can notice those purple lesions on the shin of the lady. You can notice this big lymph nodes in the chest of the patient. So what we are talking about here is a hilar lymphadenopathy in a female. These could be pressing on the trachea, contributing to stridor and breathing difficulty. And at the same time, there is this purple lesions, which we can call them as erythema nodosum. So the disease that I'm talking about at the moment is sarcoidosis. And it says like, what would be the correct feature in this particular case? Yes, sarcoidosis. So you need to comment on a question which would be having which fits the bill with respect to sarcoidosis. Virchow cells are what you read with respect to leprosy, and then is for tuberculosis. So what I need to pick up in this particular question would be a non-casetic granuloma. So yes, guys, I expect you guys to quickly comment on the answer in this case. Which would be a more appropriate statement? Yes. Okay. So two close matching statements here. Yes, one is a necrotizing epithelioid granuloma. Second is a epithelioid histiocytes without central necrosis. So I think between the two close wordings here, we'll go with option number D, that is epithelioid histiocytes without a central necrosis. That goes in favor of more of a non-casetic granuloma, because casetic granuloma will always be having a central necrosis present. So I agree to the fact that between B and D, there are close wordings present, but yep, considering that there would be a epithelioid without a central necrosis, the answer would be given as option number D. The bottom line is it was an integration between more of not exactly an integration, man. It is just that they were saying what is definition of sarcoidosis in a one-liner, but they tried to extend the question by giving you that hilar lymphadenopathy with a female patient, and then the stridor part component given with erythema nodosum. So the final answer in this case would be given as option number D. Yep, there's no central necrosis present, so that's why the answer is option number D here. Okay, so moving ahead in our discussions, next we focus on these aspects where you can see this is again a NEET PG question here. हाँ कोई बात नहीं, वो हल्का हल्का गलती होता रहेगा. क्लोज ऑप्शंस विल बी देयर इन द पेपर ऑल्सो, सो यू हैव टू बी वेरी वेरी केयरफुल. पूरा 2-2 घंटा डेली प्रैक्टिस करा करो एमसीक्यूज की. Like you're sitting with me here, it's almost 1 hour plus, right? You need to do this on a daily basis, and once you practice daily, then it will become a second nature. You can have a cobweb coagulum in this case, and then you can see that this would be a ZN stain, where you can see the red bacilli. So the interpretation in this case would be a query tubercular meningitis, and therefore we need to start empirical, because the main diagnostics in this patient, I mean the investigation of choice in this particular case would be a CSF culture for Mycobacterium tuberculosis, and the culture report will take some time to come. So I can do a I mean obviously I can do a PCR, I can do a CB NAT, but ideally like it is a CSF culture for Mycobacterium tuberculosis. So I need to be like a little more proactive and wait for the culture report before I say it is a sure tubercular meningitis. So I said empirical antitubercular treatment would be started. Question for you guys, routine culture, solid culture will take like 6 weeks to turn positive. So the liquid indicator will be used. So question for you guys, what is the name of the liquid culture media that we use for Mycobacterium tuberculosis? I mean, I'm talking about that Bactec 960 system. In that Bactec 960 system, we use a liquid indicator for growth of Mycobacterium tuberculosis. So can I have the name of the liquid culture media? Like this could be a question where they can be mentioning of what liquid media would be used to confirm the diagnosis. Yes, multiple growth indicator tube. Yes. So the liquid media that we'll be using in this case would be called as Middlebrooks media. Exactly. This would be answered as Middlebrooks media. Very good. This would not be LJ media, because LJ media is a solid media, and LJ media will take like weeks altogether to turn positive. So what we need to do in this case is use a liquid that is like a Middlebrooks media, which has a turnaround time of about 48 hours with the Bactec 960 system. So we are sorted for the 28th one. In the next image, you can see that there is a turbid CSF. That tells me that this would be pyogenic meningitis. And then what you can put up is you can check out that there are like two blue spots which are present here. So this is the Diplococcus. And the moment I say that this would be a Diplococcus in a patient, this means that this guy is having a pneumococcal meningitis. So this time they'll ask you the etiology, they'll ask you to interpret a gram stain. And if I change this to a gram negative, then it is Neisseria meningitidis. But considering a Diplococci gram positive, this would be a pneumococcal bacterial meningitis occurring in a patient. Those guys will be okay. Everybody can answer this. What empirical antibiotics would be started in this guy, considering that the age of the patient is more than 55 years of age. Okay, age of the patient is less than 55 years first. In any case of bacterial meningitis, if the age is less than 55, what empirical antibiotics would be started? So your answer would be combination of the two, that is ceftriaxone. And along with that, we'll also be using vancomycin. Vancomycin is not being given for any staph aureus resistance, but vancomycin is given because they can be resistance to ceftriaxone. So it is vancomycin plus ceftriaxone that would be given. And if the age of the patient is more than 55, then we need to give additional coverage with ampicillin, because lots of times Listeria monocytogenes can be present as well. So the answer is vancomycin and ceftriaxone. I had very good answers here. And ampicillin for old age or alcoholism if added in a question. Okay. In the next case we had was a bloody CSF. You can see bloody CSF. And along with this bloody CSF, when we have done centrifuge, so the RBCs are settling at the bottom, like we did centrifugation of the sample. So the RBCs are settling at the bottom as well. So there's a bloody CSF. Yes. Okay. And then you can check out the MRI of this patient as well. The MRI of this patient is showing a temporal lobe inflammation. Guys, it is not a case of subrectal hemorrhage. Not every case of bloody CSF would be having answer as, not every question on a bloody CSF would be having is a answer is a subrectal hemorrhage. What you need to pick up in this question is the core aspect, which is that you are having a temporal lobe inflammation present. And the moment I said temporal lobe inflammation present, the answer will change to that of herpes simplex 1 encephalitis in a patient. Obviously, we can have a traumatic lumbar puncture contributing to a bloody CSF as well. But what I'm trying to say is that this would be a distraction on the part of the examiner. In the image 29, what we have done is that there is a distraction on the part of the examiner that is beginning with a bloody CSF, but then you need to check out whether there is any blood in the sylvian fissure. whether there is presence of any blood in the interhemispheric fissure or in the basal cisterns, or is there a star of death? There is no star of death here. I'll highlight this once again. The white that you see is regarding the involvement of the temporal lobe. There is a temporal lobe inflammation that is given in this question. So a lot of these questions can be having distractions as well, like is present in this case, which will change the answer. We'll do a PCR herpes simplex 1 encephalitis in this case. And then what we'll do is subsequently we'll go ahead and start empirical treatment. So like, yeah, no Star of David in this case, as Raghav said, and no blood in the sylvian fissure. In fact, star of death is like less likely to be asked nowadays because it has already been asked in the paper earlier, and it is like mainly the blood in the sylvian fissure that is asked. So we'll do a PCR herpes simplex 1 encephalitis. Okay, so moving ahead in our discussion, we have a 3-tube test for CSF. Why we do this is mainly to check up is differentiation between whether it is a traumatic lumbar puncture, because if it is a traumatic lumbar puncture, you will have a gradual clearing of the sample. But if it is a subrecurrent hemorrhage, then there would be no change in the bloodiness of the CSF of the patient. So it is like a combination of, yeah, blood is also a very good finding that is present. So we have to differentiate, and I'll say this once again, bloody CSF is seen in traumatic lumbar puncture, in subrecurrent hemorrhage, and also in a case of herpes simplex 1 encephalitis. So do check out whether the question is given for blood in the sylvian fissure or whether it is a temporal lobe inflammation. Okay, so the answer for 29 is herpes simplex 1 encephalitis. Okay, so quick comments here. This guy, he is having like fever for 2 days. He's having altered sensorium. He's not recognizing the family members. The GCS of the patient is 8/15. Bilateral Babinski sign is present. The CSF of the patient is totally clear. And the cell count is also normal. But the peripheral smear is showing a parasite. That parasite that you can pick up in this case is the banana-shaped gametocyte, and then you can see the ecole forms or the ring stages. You can see that it is not one, but it is a multiple ring stage present. So considering that, the diagnosis in this case would be given as cerebral malaria. And considering cerebral malaria, we have to give artesunate in this patient. Primarily, that would be the main treatment. Yeah, the answer in this case would be given as cerebral malaria. The main thing was he mentioned regarding low GCS bilateral Babinski, but then the peripheral smear was given, and you can see that CSF is taken in 4 test tubes, but the physical appearance of the CSF, at least the color of the CSF, is looking pretty decent. Obviously, we need report of cells and sugar, which I said were given to be normal. So then it is like a cerebral malaria, which would be thought of as the cause of this presentation. Moving to the neurocutaneous disorders in central nervous system, what you can notice is that ash leaf macules. Along with ash leaf macules, you can also see this tumor, which is originating from below the nails of the patient. This tumor, which is originating from below the nails, is called as Queenan tumor, or instead of calling it Queenan tumor, it may also be written as subungual fibroma. This would be a tumor that would be starting from below the nails, as you can see here, a subungual fibroma. Then he can ask you regarding this manifestation, which is present on the face of the patient. This would be adenoma sebaceum. This would be having is a acneiform distribution. Then they've asked about this particular lesion, that is a Chagrin's patch. Chagrin's patch will be having is a orange peel consistency. Again, it would be present on the trunk of the patient. So one will say on the face of the patient in a butterfly distribution, you have acneiform lesions. These acneiform lesions will develop at the time of puberty. That is called as adenoma sebaceum. Ash leaf macules would be present initially. You have to tell me the MRI finding in this guy. Quick answers, please. What is the MRI hit finding in a patient with this neurocutaneous disorder? Tuberous sclerosis is perfectly fine. I mean, you are spot on here. This is a tuberous sclerosis. Yes, it is a subependymal giant cell astrocytoma. It is a SIA or a SIGA. So your complete statement would be, it would be a subependymal. Yeah, potatoes in the brain is a good answer here. But yeah, this would be, yeah, periependymal astrocytoma or subependymal giant cell astrocytoma. Giant astrocytoma can be present in this patient. That is like potatoes growing in the brain. So great, very nice. Tuberous sclerosis, most of the time it will contribute to seizures right in the first year of life only. That is why epilepsy in a young age can contribute to mental retardation. If he says what drug would be given in this case for management of the salam seizures that can be seen, we can be using vigabatrin in these patients. In the second question, the manifestations are those of Sturge-Weber syndrome. In Sturge-Weber syndrome, one, you can notice a port wine stain, and second, you can check out is the railroad calcification. So considering the railroad classification on a CT head along with this port wine stain, the answer would be given as Sturge-Weber syndrome. This is a ipsilateral cavernous angioma that is occurring in this patient, and this ipsilateral cavernous angioma is the reason why the manifestations of seizures could again be developing in this patient. Along with this, even eye involvement can be seen. The usual eye involvement that is seen in this patient would be glaucoma or buphthalmos. Yes, that would be a tram track appearance or a railroad calcification. Great. Moving to the next question, what you can see is presence of Lisch nodules. What you can check out here is the cafe-au-lait macules. What I want to bring to your attention is that cafe-au-lait macules, obviously they will be brown in color and the ash leaf macules will be whitish in color. Plus you can check up the Lisch nodules here. That would be hamartomas. Then you can see the small potato growths which are present here, and there's a optic glioma also present. Considering all the manifestations which are present, this would be NF1, that is neurofibromatosis 1. Autosomal dominant, obviously, and would be having chromosome 17 as association. And what they've asked is a tumor associated with neurofibromatosis 1. The tumor that can be associated with neurofibromatosis 1 can be pheochromocytoma. Obviously, we have association with optic glioma, but then even pheochromocytoma can be associated with neurofibromatosis 1. Great. Yes. Very good. You can pick up the optic glioma. We can have a pheochromocytoma. Moving to the last one. In this image, you can notice that the cerebellum of the patient is showing volume loss. Like you can see that the cerebellum is looking atrophied. So I can say volume loss in the cerebellum. Spinocerebellar pathways are getting affected. Plus you can see the red ataxias which are present here. So the diagnosis in this case would be given as AT. That is Ataxia-telangiectasia. Let me know what kind of cancers can be occurring in this patient. Ataxia is understandable. Spinocerebellar pathways are involved. Telangiectasia. What kind of cancers can be present in these patients? Neurofibromatosis 2 will be having is acoustic neuroma present. Yes, AT is sorted. AT, which kind of cancers can be seen in this patient? Yes, lymphoreticular malignancy. So leukemia is more common, or I can say lymphoreticular malignancies would be more common in this patient. The tumor that can be seen in the hemat malignancy that is usually seen in these patients would be leukemias. That is lymphoreticular malignancies. So AT is like ataxia, telangiectasia, and LRM risk that would be increased. Yeah, I mean, I asked regarding a hematological malignancy. You could be having is autoimmune disorders present. Okay. In the next case, what you can notice is that the patient is having a tumor with respect to the pituitary in the T1 image. This is, I mean, you can see that there is a definitive contrast enhancement that is present in this case. And there's a tumor that is associated. Yeah, the chromosomes are okay, guys. That is what you cover in pathology. And you can see a tumor mass. And then you can also notice that there is a bitemporal hemianopia. So this would be a no, we'll not call it a craniopharyngioma. We're talking about an adult at the moment. You are seeing a pituitary tumor and a bitemporal hemianopia. So craniopharyngioma will be having like this, no? Craniopharyngioma will have a calcification, and inside this will be black. In craniopharyngioma, the outside is white, wall is a calcification, inside is cystic. So here it is a uniform, like, you can see the anterior pituitary, you can see the, I'll mark it here also, you can see the posterior pituitary that is more bright. And then you can check out is the anterior pituitary, which appears relatively bigger. So this is not a craniopharyngioma, because craniopharyngioma will have a calcification in the periphery, the white, like I mentioned, and then there's gonna be like the black, but this is uniform pituitary adenomas. This could be over secreting growth hormone. It could be secreting prolactin. So patient could be either having a prolactinoma, and considering that adults also, I mean, two that I'm suspecting in this patient is, one is a possibility of a TSH, one is a possibility of a growth hormone secreting adenoma, that is acromegaly, and the second possibility is prolactinoma. And in both of these conditions, then you'll ask about the medical management perspective. In acromegaly, we usually give lanreotide injections. For lactinoma, cabergoline and bromocriptine can be used. Okay, moving to the inferior diagram, one, you can notice that there is a neck swelling which is present. You can notice sinus tachycardia also coming up because the heart rate of this patient would be like maybe 125 beats per minute. So combination of a neck swelling along with sinus tachycardia, and along with that, you can see the stare sign coming up in a patient. This you guys can quickly comment in stare sign, like which muscle of the eyeball will be retracted to cause this manifestation. Which eye muscle would be involved in this case? Yeah, pituitary adenoma producing a growth hormone or prolactin is the possibility. Yeah, we talk about Graves only. The muscle that is involved here in stare sign would be Muller's. Yes, Muller's muscle. And the patient would be having Graves disease. So the interpretation is Graves as rightly put up. Can you quickly tell me the antibody for Graves disease before we move on? No, it is not levator palpebrae superioris, but it is the Muller's muscle. Can you tell me the antibody for Graves disease? That TSH stimulating antibody. Quickly, guys. You can pick up the neck swelling or diffuse swelling of the neck. There is the stare sign given. We're talking about this. Okay, very good, very good, very good. Okay, LATs. The technical name is actually LATs is just to make it easy for you. The antibody which is present here is the TRAB, that is TSH receptor stimulating antibody. So LATs is for English version that I said long acting thyroid stimulating antibody. But what does it stimulate is the TSH receptor. Antibody बेफूबनारी receptor को, it's stimulating the receptor to produce more T4 and T3. So the TSH will go down. So it is TSH receptor stimulating antibody, which is the one that I have mentioned at the moment. So Graves. And the main treatment for Graves disease, according to American Thyroid Association, would be to go ahead and give radioactive iodine to these patients. That is iodine 131. That is thyroid ablation will be useful for management of this patient. Yeah, Vaibhav, you're right. I mean, it's the inferior rectus muscle that can be involved. Absolutely. Moving to the next one, again a very easy one. There is a neck swelling described, and then you can notice this neck swelling is also having a stony hard consistency. And apart from stony hard, you can pick up that orphan ani nucleus here. So the tumor that we are thinking in this case would be a papillary cancer of the thyroid gland. PCT is what I'm thinking in terms of papillary cancer of thyroid. It usually has a lymphatic spread. So it has like unlike follicular, which will have a hematogenous spread, papillary cancer would be having is a hematogenous spread. Another finding that is asked for this would be Samoma bodies. Okay. Okay, moving to the next one. You guys can help me out for the next one. You can notice calcification of the basal ganglia. Like this CT head can show 2 points. So there is a calcification of the basal ganglia. And you can also notice that the patient is having a carpopedal spasm. Carpopedal spasm or trossius sign is present in this patient. So there is a hypocalcemia in this particular case. Yes, guys, quick answers, please. Phosphate is elevated. Serum alkaline phosphatase is normal. So which condition do you read this report where you get a carpopedal spasm? No, bacha, you don't get Wilson disease. Will be having Wilson has copper deposition in the lenticular nucleus. No, that is the manifestation that is called as giant face of panda. At the moment, we're not talking about giant face of panda, and Wilson will not be having a carpopedal spasm present. So, a condition in which you get this report would be where the person would be having is a deficiency of parathyroid hormone, that is hypoparathyroidism. Hypoparathyroidism causes hyperphosphatemia, and hyperphosphatemia is responsible for calcification of the basal ganglia. The first thing you are to supposed to note in this question is some questions are going to be super easy, no, like that orphan nucleus is, you guys have read it some multiple times. So one question you will attempt is super easy. The next question will make you think. So you need to develop and learn the skill of saving time in a question so that you can attempt the next one. These two questions were put together to sensitize you to the fact that some questions are going to be so simple that you'll be wondering like, why did you need anything like, you know, a app or anything or some guidance? You could have done it by yourself. And there are some questions which will make you think. So the second one is of that particular quality type. And for this, you need more than 1 minute to solve. So you have to save time in some of the easy ones and invest it at the right time. So that's what you call as cherry picking, that you are able to pick up the question, especially those of you who are going to be sitting for NEET PG. Negative marking is of paramount importance. So first grab those easy runs and then pick up those ones where like you can take a risk as well. If you're aware of at least 2 options out of 4, just go for the hit. Otherwise, like you can let it go. Okay. No, pecan would be that pecan is gonna be in the putamen, no? There it will be black and white, right? So there's gonna be difference, no? The putamen, and there would be no carpopedal spasm that is present in the eye of the tiger. Eye of the tiger would be a manifestation of pecan, where there would be a neurodegeneration in a child. So there would be no hypocalcemia manifestation described in the question. Hungry bone syndrome beta is after when you have like treated a patient of let me say I mean when you start these replacements, right, when you start nutritional rehabilitation in a patient, that is when all the calcium goes inside. Like the patient is having extreme amount of malnutrition and you have to start total parental nutrition. That's when you give these nutritional supplements and they go inside, and that is why like the hypocalcemia manifestation can occur in a patient. Okay, so yes, the next one is pretty spot on by people. I got lost in a bit of chit chat here. Yeah, picture frame. So this is a Ruger jersey spine. Very good, very good. You can pick up a Ruger jersey spine, the picture frame, and along with the Ruger jersey spine, you can also pick up the diabetes manifestation here. That would be that the patient is having nodular glomerulosclerosis. So the moment I see a combination of the two, that there are bone changes also occurring and there is a diabetic manifestation also given, I know that I'm dealing with a case of chronic kidney disease. And the final diagnosis in this patient would be like in the MCQ, there was no mention of any Ruger-Jersey spine. He said, what is your final interpretation? So your answer would be based on the combination of the two images that the patient is having secondary hyperparathyroidism. Yes, guys, the final answer is that your patient is having secondary hyperparathyroidism. I think everybody knows the logic, but I'll say it quickly. कि CKD में the production of vitamin D in the body will be less. If vitamin D is less, then calcium in the body will become less. If calcium in the body will become less, there would be a secondary increase in PTH. That is why this is secondary hyperparathyroidism. And yeah, I mean, you guys were very spot on in being able to identify the Ruger jersey. But the question was like a combination of the two. Ruger jersey spine is a feature of CKD and a nodular glomerulosclerosis. So the correct interpretation for this would be answered as that the person is suffering from a secondary hyperparathyroidism. Yeah, in secondary hyperparathyroidism, the calcium will be low, PTH phosphate will be more, and serum alkaline phosphatase will be elevated. Na? Whereas in hypoparathyroidism, the report that discussed in the previous page, the serum alkaline phosphatase report was normal. Here, calcium will be low, understandable, phosphate will be more, and serum alkaline phosphatase in this case will be elevated. Whereas in the previous report of hypoparathyroidism that I explained to you, you notice that the value of serum alkaline phosphatase was normal. So that calcium metabolism part is what I've already discussed in the earlier part. And yes, I think the next one was picked up renal osteodystrophy. Darshan, a very good word that you put up. The next patient of mine is having an excess of ACTH. This increase of ACTH can be seen as causing hyperpigmentation in the gingiva of the patient. We can see hyperpigmentation on the knuckles of the patient. And he's also mentioning that the patient had undergone a post-bilateral adrenalectomy. You can notice that the pituitary enlargement in the patient is seen. What you can see in this case is that post bilateral adrenalectomy, there is the pituitary enlargement. So the diagnosis in this case would be given as Nelson syndrome. The highlight of this Nelson syndrome would be hyperpigmentation that would be seen at the sites, which would be like the gingiva or the hands, dorsal of the hands of the patient. And anyway, the main hint in the question, which everybody could pick up, was a post bilateral adrenalectomy. If I did not even write that word, then you will have to figure out the combination of these two images, that is hyperpigmentation plus pituitary enlargement. If I had not written this, I mean, this was only done to make it easier for you. So you were able to pick up Nelson syndrome immediately. But after this, like after the discussion is done, I think you can pick up that if you get a combo of this hyperpigmentation and along with that, you get a pituitary enlargement, you are spot on for Nelson syndrome, even if in the question, the word bilateral adrenalectomy is not given. So very good spot on answers there. Okay. So salt and pepper histology is what I mentioned, like, you take that pepper balls and the salt, the granular salt, and you can see that very characteristic pattern for a tumor that I don't need to say. I'm waiting for you guys to comment. Yes, guys, quickly, let me know. This is the kidney, right? And just above the kidney in the suprarenal gland, there is this ill-defined mass, and this looks to be like infiltrating into the adjacent tissues as well. And the salt and pepper histology is also given. So yes, the answer of yours would be given as pheochromocytoma. Very good. The answer of yours would be given as a condition where we read about the rule of 10. This would be a pheochromocytoma. And I mean, now I don't need to, if I now, even if I erase the word salt and pepper histology, you can get it correctly here, considering that there would be a pheochromocytoma. Yes, this manifestation has also been asked in FMG exam as nests of Zellwollen. The technical term that was given in FMG exam was nests, no, the nests appearance of these cells, no. So the nests of Zellwollen as a term is also given in FMG exam, and otherwise I think the common mode term that is used is this salt and pepper histology. Great. Moving to the next one, yeah, pheochromocytoma. One aspect which I want you to just say quickly is for preoperative hypertension, what medicine would you like to give to this patient? Yeah, paraganglioma is the extradural one. Yeah, quickly guys, preoperative hypertension for pheochromocytoma, the medicine to be given. मेटानेफ्रिन बच्चे, इट इज मेटानेफ्रिन विच इज द मेन टेस्ट फॉर दिस कंडीशन. वेनियाइल मेंडेलिक एसिड जो होता है ना वो न्यूरोब्लास्टोमा के लिए यूज होता है. वो एफएमजी एग्जाम में ना उसने जो क्वेश्चन का रिकॉल है वो गलत है. वेनियाइल मेंडेलिक एसिड इज फॉर नॉट फियोक्रोमोसाइटोमा, इट इज फॉर न्यूरोब्लास्टोमा. वो बात ठीक है कि अब नहीं दे रखा क्वेश्चन में, तो न्यूरोब्लास्टोमा भी मेडुला से होता है और फियोक्रोमोसाइटोमा भी मेडुला से होता है, तो वेनियाइल मेंडेलिक एसिड कर देना. बट टेक्निकली फॉर फेनाइल के उम्र फियोक्रोमोसाइटोमा इट इज मेटानेफ्रिन. Very good. It is alpha plus beta blocker. वो नाम जो है phenoxybenzamine and propranolol would be used in the patient. Great. In the next question, my patient is having oral phenoxybenzamine. Anubhav, you perfectly right. You can notice the pigmentation of the gingiva. You can notice the hyperpigmentation in the palms of the patient. So this guy is having an excess of ACTH, and then is the characteristic word salt wasting, low libido, low sugar, and low blood pressure. So all of these point towards that this guy is having Addison disease. You guys have to quickly comment on not the diagnosis. Please tell me the screening test for this condition and the investigational choice. Quick comments. Yes, very good. Addison disease is very correct answer given by everybody. And now I would like you to comment regarding the screening test for this condition and the investigation choice. Yes. Okay, Shrishti was the first one to mention regarding one of the tests that we are going to be using in this patient. Yes, fluid loading. Okay, salt is coming up. Very good, very good. Post-entropin is a good answer. Yes, so I think the investigational choice, we can just focus on IOC part only rather than focusing on too many things here. So I'll keep it simple. IOC is fine. ACTS stimulation test. And that ACTS stimulation test is also called as post-entropin test for this patient. But some people mentioned as saline infusion test. That saline infusion test is for Conn syndrome. No, like in Conn syndrome, there's a tumor. So what you have is that saline infusion test will fail to suppress the aldosterone production. So do take care of that and try to just practice the investigation choice for each of these endocrine conditions. Okay, quick answers here. Patient is surgery / medicine / radiology. Yeah, but that's what I'm saying. A salt loading test is for Conn syndrome. Saline infusion, salt loading is for patients, and hydrocortisone is the drug of choice. Perfectly right. Okay, so a patient of mine, this particular person is having a unilateral parotid enlargement, and then there is a hot nodule which is present. So considering that there is a hot area present here, the black spot which is present, you guys can quickly comment here for the answer for this question. Yes, very good. Very good. Pleomorphic adenoma. In this particular patient, there is weight is normal and nerve palsy is not there. So that rules out the possibility of a cancer. Cancer will usually spread, and like even in this scan, it's a limited scan only. What I can pick up is that there is a hot area present, and once the hot area, I think somebody asked this in the telegram also. The hot area is gonna be for Warthin's tumor and not for pleomorphic adenoma. Pleomorphic adenoma will always be cold. Pleomorphic adenoma is always cold, and Warthin's tumor will always be hot. So that's how you differentiate in this particular case. I mean, remember, pleomorphic adenoma is a painless, parotid, persistent enlargement and pertechnetate cold. So a couple of P's there, which will make it easier for you. Painless, parotid, persistent swelling, and that can cause that curtain sign coming up. The earlobe of the patient would be elevated, and it is pertechnetate cold. Whereas when it comes to Warthin's tumor, it would be pertechnetate hot. I mean, that's the differentiation between Warthin versus. I agree that unilateral versus bilateral fight will also be there, but then if it's a single tumor, I need to pick up on the basis of uptake then. The answer is A. Okay, moving to the next one. What you can pick up here is a very classical manifestation of swan neck deformity, where you can see that there is a extension and a flexion. Like this is PIP, this is DIP of the patient, and I can notice that there is a extension at the PIP and a flexion at the DIP. So this would be a swan neck deformity. Apart from the swan neck deformity, the opposite of this is what is called as a boutonniere deformity. And along with this, you can also pick up the most common extra-articular manifestation of this condition. Quick comments, please. What is the commonest extra-articular manifestation that is seen in patients of rheumatoid arthritis and is given up very well? Yes, guys, quick comments, please. What is the extra-articular manifestation, the commonest one? Yes, your answer would be rheumatoid nodules. These rheumatoid nodules would be seen on an extensor distribution as is present in this case. And then in the finger of the patient, there would be a Z-line deformity present. So you can see three things present here. The final interpretation is that the case that we're talking about is having rheumatoid arthritis. In this particular case, the screening test would be RA factor, and the investigation choice would be anti-CCP antibody, that is cyclic sertraline peptide antibody, and then we start triple therapy in these patients. Triple therapy would mean that it is methotrexate, along with this is hydroxychloroquine, and along with this would be sulfasalazine for management. And we do have biologicals for these patients, for which they usually like to ask regarding a JAK3 inhibitor for this condition, that would be tofacitinib. So anti-CCP antibody, triple therapy, and tofacitinib JAK3 inhibitor is one of the common things that they like to ask about rheumatoid arthritis. Okay, fine. Let's hit the comment buttons again in this patient. Yes, very good. You can pick up this homogeneous pattern, and the moment you pick up this homogeneous pattern, we are thinking in terms of, I think it's written there already, but still, okay, we think in terms of SLE, that is systemic lupus. RA factor is for screening, RA factor is for screening. You can see the very characteristic homogeneous pattern that would be seen with respect to patients of SLE primarily with the, yep, absolutely right, absolutely right. The antibodies are antibody against double-stranded DNA or anti-histone antibodies. Yeah, the homogeneous pattern that is seen. Great. So I have a question for you in the SLE component. Yeah, this is the question here. Can you comment on this loops that you can see in the kidney biopsy? I mean, the question had to spread over two lines. Like this is the pattern in the blood, the homogeneous pattern that we're picking up. So we know we're dealing with the autoimmune panel. And yes, so there are two things present here. The immunofluorescence in this case is showing all antibodies. Antibodies are IgG A class, G, then M, then complement factors are also present. So as people put up very rightly, this would be called as a full house effect. And then there is a light microscopy finding also given here, the loop that I mentioned. So quick answers, please. The light microscopy finding in this case would be called as wire loop lesion. Very good, very good. So this is one of the important causes of mortality. One of the pop singers, Serena Gomez, she has lupus, and she had to undergo kidney transplantation for the same. These would be wire loop lesions, which are very characteristic for how many histopathological grades of glomerulonephritis, lupus nephritis? There would be 6, and the commonest one and the severest one happens to be gonna be the type 4 only. So okay, yeah, fingerprint in electron microscopy. That's a good one. That's a good input, Aishwarya, from your side. Okay. The next case is what I have already discussed, but still I wanted to mention regarding the skin manifestation of this. So you can see that massive hilar lymphadenopathy. You can also check out the non-caseating granulomas without any evidence of sarcoidosis. Yes, the skin manifestation in this case that you would be answering in this case would be given as lupus pernio. Yes, that's the skin manifestation. Lupus vulgaris is skin TB, but the skin manifestation that would be present here would be that for sarcoidosis, that would be for lupus pernio. Investigation choice for sarcoidosis, please. Yeah, BAL value CD4, CD8 would be more than 2, usually more than 3.5. What is the investigational choice for this condition, guys? Can I have quick answers, please? I mean, X-ray, CT scan, BAL CD. Yes, 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 yes. Hmm. Yes. So the investigational choice for this guy, yes, the best way would be to go in for a tissue biopsy. So we either can go for a lymph node biopsy, or we can go for a lung biopsy in this patient. I mean, wherever possible in this particular patient, our first answer would be a bronchoscopy and a biopsy. And this bronchoscopy would let us enable that whether we want to take a sample from the lymph nodes or whether it is from the lung tissue in a patient. So bronchoscopy with a biopsy. And yeah, we will also be using the bronchoalveolar lavage fluid, where we check for the CD4 CD8 ratio in this case, which would usually be more than 3.5. So yes, I mean bronchoscopy with a tissue diagnosis would be the best for diagnosis in this case. Okay, so slightly tricky one, not exactly tricky, but yeah, it is related to the previous disorder that we're discussing only. So one you can pick up that this person is having livedo reticularis. This patient is also anti-nuclear antibody positive, anti-Smith antibody positive also. And here you can see these lesions on the face of the patient. Yes, this would be a discoid. Yes, this would be a DLE. This could be discoid lupus erythematosus. Yes, this is a discoid rash which is present. That is present again in a case of systemic lupus erythematosus. So considering that livedo reticularis ANA was given and then anti-Smith antibody, this would be a discoid rash. We can either be having that classical butterfly rash manifestation, or it could be a discoid rash manifestations that would be given in the question as well. So great. I mean, considering that we are having a anti-nuclear antibody present, so that is why I am saying that we have to think not in terms of a drug, but have to think in terms of that cutaneous manifestations. Okay, great. So yeah, this is the butterfly rash that we see in SLE, and you can see that it is not going to be involving the eyes of the patient. So this is just given for comparison sake. This is the butterfly rash. This can usually worsen on sunlight exposure, but the image which is adjacent to this is the one which is mainly being asked, where the rash is around the eyelids of the patient. So considering the rash is around the eyelids of the patient, this would be called as a heliotrope rash. The image on the left is only for comparison. We are having a heliotrope rash. Therefore, the disease that we'll be thinking in terms of would be DM, that is dermatomyositis. For dermatomyositis, the investigation choice would be a MRI guided muscle biopsy. Though we have antibodies also, but then it is a MRI guided muscle biopsy that would be more suited for these patients. Now we move on to 52. 52, if you check out, you can notice calcium deposition in the skin. So this calcium deposition in the skin is what is called as calcinosis cutis. That calcium deposition in the skin is called as calcinosis cutis. You can also notice that there is loss of creases on the IP area. Like in our figure, like you have these creases. So you can see a digital ulcer. One you can see in this patient is a presence of a digital ulcer. Second, apart from digital ulcer, what you can see is these ischemic ulcers. You can see this loss of IP creases. That is sclerodactyly that I'm saying. I actually wanted to avoid saying the word sclerodactyly because that would have made the answer very, very obvious. But anyway, since I've said it, so it's okay. Distal ulcer, loss of IP creases. Sorry, not joint. It is IP, means interphalangeal joint creases. We have loss of interphalangeal joint creases. There would be calcium deposition in the skin, calcinosis cutis, and somebody mentioned very beautifully that this would be salt and a pepper skin. So that means that you've done your derma part well as well. The answer in this case would be given as scleroderma. Quickly comment on the antibodies. If this is systemic sclerosis, if this is scleroderma, which antibody would be present? If it is systemic sclerosis, which antibody? If it is systemic sclerosis, then the antibody present. And yeah, for antibody for crest also. Very good. For crest, the antibody would be beginning with C only, that is centromere. And for systemic sclerosis, the antibody would be as topoisomerase antibody. Quick comments. What is the leading cause of death in scleroderma? Cause of death in scleroderma, like in SLE, it could be either heart disease or it could be kidney disease as contributor. In old people, it is heart disease. Younger people is kidney disease. In scleroderma, the reason cause of death would be, yes, one option came up very well, scleroderma crisis, but usually we manage it well with blood pressure. Yeah, the usual cause of these patients in scleroderma, the cause of death would usually be a pulmonary artery hypertension that could be contributing to the, I mean, loud P2, low DLCO can be the reason why these patients can die. So it is not scleroderma crisis as the cause of death, though it looks like that, because when you read the word scleroderma crisis, the thought process of ours is, oh man, there's going to be a kidney involvement, so the person will die. But for scleroderma crisis, what we do is ACE inhibitors can be used. So yeah, pulmonary artery hypertension and interstitial lung disease is a good enough answer. Okay, so the next patient of mine, I'll say the answers here. This guy is having sacroiliitis. As you can see bilaterally, if the same patient is not treated, he'll end up with bamboo spine. The question for you guys is, what is the drug of choice here? So please comment not on the diagnosis, but on the diagnosis, not on the diagnosis, but on, right? This patient is now looking like a question mark sign, right? The patient is having a very severe kyphosis present like this, no? So question mark sign is what I've described. So what is the drug of choice for this patient? Yes. This is ankylosing spondylitis. In ankylosing spondylitis, we need to do a MRI. The MRI should be showing us evidence of a bone marrow edema. Yes, bone marrow edema. HLA-B27 positivity alone is not sufficient for diagnosis of this condition, so I'm writing it subsequently. HLA-B27 positivity can be seen in psoriatic arthritis. It can be seen in ankylosing spondylitis, inflammatory bowel disease, and reactive arthritis. The mnemonic for this, as you read, is pair. So if you want to read the mnemonic, it's okay. Psoriatic, ankylosing, inflammatory bowel disease, reactive arthritis. But the main imaging modality is not an X-ray; it is a MRI. And I asked the drug of choice for this condition. So we manage the patient with painkillers, but then it is the biologicals which is the main treatment for this patient. So we use tofacitinib in these patients. A lot of them who are not ready for infusions, we give tofacitinib with sulfasalazine. You'll notice most patients of ankylosing spondylitis being prescribed tofacitinib and sulfasalazine oral, and infliximab as infusions otherwise. Very good, very good. I think Dr. Banu, Famida Banu, you were spot on for this. Okay, so this patient of mine is having these white lesions on the ears, and this guy is also hypertensive. This is a 55-year-old guy. He's a hypertensive. He's on thiazide diuretics. And today he came to the hospital with these white lesions on the ears, on the helix of the ear. These white lesions are present. And this guy has also had pain in his metatarsophalangeal joint last year, which was so severe that he required painkillers as well. I think I made myself clear now. So can I have the answer in this particular case? Yes, please. Yes, very good, very good. Thiazides would mean that it will contribute to increase in the uric acid level. And along with this, metatarsophalangeal joint involvement is also given in the question, in which the patient had to, come to the hospital. He had to take painkillers for a few days, after which the pain went out. So our diagnosis in this case would be given as, yeah, you have to not answer as gout. No, that is understandable. The moment I say the word uric acid is elevated, that means that this would be gout only. And if I say MTP joint involvement, it will be gout only. You will say that the patient is having TOFI. Your final answer is the person is having TOFI. TOFI are a presentation of chronic gout. This particular gentleman is on thiazides. He is having MTP joint involvement. Maybe he consumed a lot of alcohol also, takes a lot of non-veg also, has not followed the doctor's advice. So therefore the diagnosis in this case would be deposition of uric acid in the skin. And yeah, there are negatively birefringent crystals, but at the moment is not having a joint swelling. Na? At the moment the guy is not having any joint swelling. So no, we'll not give raspberry case for this particular case. For chronic gout, we have to give allopurinol and febuxostat for management. If it is the overproducer, if it is the under excreter, then we'll be using probenecid for management of this patient. That will be based on the 24-hour urinary uric acid values. But the image-based question here was these white deposits, which are very painful in the ear of this patient. Once they develop, would be the development of TOFI, that is deposition of uric acid in the subcutaneous tissue, especially in the helix, antihelix of the ear. How to differentiate gout versus pseudo gout? We do joint aspiration, and if we see positive birefringent crystals, then it would be pseudo gout. And if it is gonna be like then it is gonna be pseudo gout. And if it is positive birefringence, and if it says negatively birefringent crystals, then we will say, I'll show you the image also. I mean, that is the image which I was waiting for, because if it's gonna be like, needle shaped negative birefringence, I'll say this is monosodium urate. Otherwise, obviously, that weak positive birefringence is which I will be saying for calcium pyrophosphate. Exactly. Okay. Fine. Yeah, needle versus, actually the shape is not very accurate, because uric acid crystals are very short, very I would say fragile, so they can adopt any shape. So it is like the birefringence word is the key word to differentiate between the two. But your point is very well taken here. And another feature that you can be seeing in chronic gout in these patients is this erosion in the especially in the phalanges of the patient. This is called as a rat bite lesion, and this would be called as Martel sign. We have four more slides here, so I think people are worrying about time. I understand you are at the last stages of your preparation, so I'll not take too much of your time. But yeah, this question I think came in FMG exam, so even if you are an FMG aspirant, guys, chronic gout की presentation दो पूछी हुई है, एक tophi और एक Martel sign. That would be the rat bite lesion that can be seen with respect to the phalanges in a patient's erosion, right? The metatarsophalangeal joints are subsequently are getting damaged in this patient. Yeah, Martel sign. Okay. This is a vasculitis. They always give a picture on this with respect to a child. The vasculitis that I'm talking about at the moment is a extensor purpura. And this is one of the common vasculitis in Western population caused by immunoglobulin A. Every time they give you a rash on the backside of the legs of a patient, backside of the buttocks of a patient, it is immunoglobulin A induced. Both भाई दोनों के लिए टेस्ट है ना. Give the test for both people. It is Henoch-Schonlein purpura which is to be remembered. भाई FMG का एग्जाम भी तो मुश्किल है ना, कोई आसान थोड़ी ना है कि मतलब 2-3 घंटे तो सुनना बनता है मेरे हिसाब से. बाकी आप वाइज लोग हो. Extensor purpura is a feature of Henoch-Schonlein purpura. Okay. A platelet count will be normal, so it is called as a because the platelet count is normal, that is why in that condition we call it non-thrombocytopenic purpura. And we can have abdominal and a renal involvement, but renal is less common now. If renal is there, then yeah, you could be having even a hematuria as a presentation. Okay. So another feature which I want to bring to your attention is for this test of nail fold capillaroscopy. This is a test that is again done in patients of scleroderma. Scleroderma, as it causes fibrosis, so it can even damage the blood vessels or the capillaries. I mean, normally the capillary loops will be having this particular shape. Here we can have dilated capillaries, we can drop out, we can have avascular zones also. So just wanted to bring to your attention this statement, which I mentioned in a main video. Nail fold capillaroscopy is used for evaluation of patients of scleroderma. Okay. Moving to some of the images towards the ends, what I'm trying to see here or show you here is the sausage fingers, or sausage digits. And what I can also show in this case is like this erosions which are present. So this is like a pencil in a cup, like you put pencil in a sharpener to make it more sharpen. So the terminal part of the phalanges is affected. I'm not saying subperiosteal reabsorption. I'm saying a pencil in a cup appearance, and along with this, there is a sausage digits which are present in a patient. The combination of the two, I can wait for quick comments here. Yes, guys. Yes. Dr. Haldar, you put up a question. I put it in the recall session, no, that if it is steroid, then steroid first is to be answered for management of person who's having a GI bleeding, not for abdominal pain. It is for GI bleeding. If severe, I've shown a flow chart. Please go to the NEET recall. Dr. Devjani Haldar, you put up a question regarding should we be giving steroids in Henoch-Schonlein purpura. The main indication is kidney involvement. After kidney involvement is GI bleeding in a patient and not for abdominal pain. Just check out the reference that I've given in the NEET recall. Yes. So the correct answer in this pencil in a cup appearance and there is sausage digits would be a psoriatic arthritis. And the next image, I think I should have included it in one of the previous ones also, but because of lack of space, I could not. But this is again a question of NEET PG that has come up, that there was presence of Gottron papules and there was a shawl sign also present. The combination of the two, that there is Gottron papules and a shawl sign, would mean that the diagnosis in this case would be given as dermatomyositis. So what we are doing at the moment is, guys, we're just focusing on those core issues. Like in a 2-hour period, if I just flip through the pages, I should be able to scleroderma. Beta, scleroderma is a complication that is seen in pediatrics बच्चे में जिसको sepsis हो जाता है, उसकी चमड़ी बिल्कुल टाइट हो जाती है. जो sepsis वाला बच्चा होता है उसमें scleroderma होता है. I understand there is a question that is given in PrepLadder on scleroderma versus scleroderma. Akshay put up that question very beautifully here, ki sir, what is scleroderma and what is scleroderma? Scleroderma is a disorder that is a connective tissue disorder where there is going to be like I mean myriad manifestations that I have described in the main video, mainly focusing on the fibrosis component. But scleroderma, the second term that you mentioned, Akshay, that is basically seen in children with sepsis, where there would be like saponification of the fat below the skin and the skin will become very tight. That is for newborn babies. Yes, can be seen in diabetes also. Can be seen in diabetes also. Absolutely. Okay, so we do two more images, guys, and we are sorted for today. Okay, hi Adil, great. If you are able to complete, I'm happy for this. Yeah, the finding that I wanted to bring to your attention was these target cells. Yeah, obviously you picked that up. That chipmunk faces picture is abused here. So what I wanted to bring to your attention is the target cells. What I wanted to bring to your attention is the chipmunk faces. And meanwhile, you can comment on the investigational choice for this condition. Quick answers, please. What is the investigational choice for diagnosis of this hemolytic anemia, which is a hemoglobinopathy? As you can pick up, it looks to be a thalassemia intermediate or a thalassemia major, going more in favor of thalassemia major, though there is no mention of any transfusion dependency given in this question. So can I have the answer, please? What is the investigation choice for thalassemia? Yes guys, the investigation choice in this case is not to be answered as HPLC guys. बच्चे मैंने बताया हुआ है, the main investigation, इसको तभी बोल रहा हूँ कि हेमैट को ना छोड़ देते हैं और मेडिसिन से सुनते नहीं है, एक बार सुन लिया करो. आई मीन दिस इज, आई हैव सेड दिस, बहुत बार बताया बच्चे मैंने. आई नो हेमैट मोस्ट पीपल्स निगलेक्ट, और वो कहते हैं पैथो से कर लेंगे. आपने क्या करना, पैथो से करो, नो डाउट अबाउट इट, वेरी ब्यूटीफुली टोल्ड. बट उसके बाद में एक बार 1.5 या 2x पे फास्ट लगा देना मुझे डिनर के बाद में और सुन लेना द इन्वेस्टिगेशन चॉइस फॉर थैलेसीमिया एज अ जीन सीक्वेंसिंग. इट इज HBB जीन. इसको सुन लो ध्यान से, ये सवाल पूछा उसने कि कैसे थैलेसीमिया का डायग्नोसिस करते हैं. इट इज जीन सीक्वेंसिंग विच इज द इन्वेस्टिगेशन चॉइस फॉर दिस पेशेंट. और जीन सीक्वेंसिंग के बाद में फिर आपका आंसर होता है दैट हाई परफॉर्मेंस लिक्विड क्रोमेटोग्राफी. उसके बाद आंसर होता है हेमोग्लोबिन इलेक्ट्रोफोरेसिस. और एमसीक्यू में तीनों दिए होते हैं, और एमसीक्यू में तीनों दिए होते हैं. So if you are a repeater, whether for NEET PG, whether for FMGE exam, you will understand what I'm saying better than as compared to the freshers listening to this कि भाई सारे options लगते सही है. इट इज द जीन सिक्वेंसिंग विच इज द करेक्ट आंसर. सो देखो यहाँ पे लाइक जैसे गाउट वाला क्वेश्चन था, तो गाउट नहीं पूछ रहा था ना यार मैं, इट वाज द स्पेसिफिक आंसर फॉर टोफाई दैट इज बी एक्सपेक्टिंग आउट ऑफ यू. या मेंसर इंडेक्स इज नेवर अ डायग्नोस्टिक फीचर ना बच्चे, मेंसर इंडेक्स इज नेवर अ डायग्नोस्टिक फीचर. द इन्वेस्टिगेशन चॉइस इज ऑलवेज अ जीन सिक्वेंसिंग फॉर दिस पेशेंट. ओके जी, एंड देन दिस इज वो HLA-DL8 वाला कंडीशन वेयर यू कैन गेट ब्लंटिंग ऑफ द विलाई. एंड ब्लंटिंग ऑफ द विलाई के साथ साथ में देर इज रीजनरेशन ऑफ द विलाई इन अ पेशेंट. तो आपसे मैं डायग्नोसिस नहीं पूछ रहा हूँ, मेरे को मालूम है कि ब्रो सीरियल्स आपको पता है. आपने मुझे बताना है कि इसके इलाज में, मेरा लास्ट क्वेश्चन है आज के लिए, फॉर मैनेजमेंट ऑफ दिस पेशेंट क्या देंगे. Yes, what is the treatment? Dapsone बच्चे is for Vigian. The Dapsone is given for treatment of dermatitis herpetiformis. So we avoid bro. What do we give for this patient? Yeah, the antibody, there is anti-tissue transglutaminase antibody for dermatitis herpetiformis. It is gonna be always epidermal transglutaminase antibody. Exactly. We give cereals. What are the cereals we give here? We give quinoa. Then we can give bajra. Then we can give poha to the patient. देवाक्स क्या दे सकते हैं. सो इट इज किनवा, बाजरा, पोहा which can be administered, and maize, makka, maize, that can be given to this patient. And along with this, we'll also be giving iron folic acid supplements for management of this patient. So guys, as far as today's discussion was concerned, it was more of a rapid fire discussion where we tried to incorporate fast the name of the topics at least had to be mentioned. And the objective is कि जो images होती हैं, they tell a story, and that is what they expect out of us. So about 10% of paper will have some images. Some of them are very simple, some of them are like where you'll have to rack your brains a bit, but I've tried to give you a basic insight into how to work up these relatively fast. So I'm gonna see you again on 21st. We'll be doing a mock discussion of all the questions. It will be all the subjects, and there we'll focus on how to rule out the two options here. So thank you so much guys, and I think you have to operate on remote memory, like you can't remember everything. बहुत सारी चीजें आप भूल गए होगे, पर जैसे थैलेसीमिया पकड़ लिया ना 2 मिनट में, बस इतना ही तो पढ़ना था. जीन सीक्वेंसिंग है, वैसे ब्रो सबको याद था, पर क्या देना है वो पूछ लिया वो. So it is just that you guys are there, you are right at that level guys, you are right at that level where you are ready to compete with anybody and everybody, right? So it is just that you need to have faith in yourself and your capabilities. And if you keep on doing work like this on a daily basis, जैसे अभी हम किए ना, almost like 40, 45, 50 पेज करे यार. 48 pages is what we have done in last less than 2 hours I will say. So if you can do like 25 pages in 1 hour, that means commendable. I mean that's not a capacity that ordinary people have. So I think with this kind of approach you are gonna do great, and we are gonna be like on fire for the next couple of days. And I'll see you again on 21st again, where we discuss those questions. Thank you so much for your patience and listening to this. The PDF of this, yeah doc, we'll do it. I put some brainstem syndromes there as well. Their brainstem syndromes are not image based questions. I've discussed them in the LRR component, I've described them in the rapid revision component. So it will become repetitive to say non-thangle and again and again the same thing. So it is like those visual memory of ECG and X-ray interpretations that I had to say to you. So yes, ऐसे ही आए, आसान वाले आए तो आप करते रहें बिल्कुल. बाकी ऐसा नहीं है, एग्जैक्ट तो नहीं होते हैं, बट या द ट्रिकी वंस विल ऑलवेज बी देयर. बट यू हैव टू, जैसे ये नेल फोल्ड कैपिलरोस्कोपी बोला तो सभी चुप कर गए ना. लाइक ऐसा नेल फोल्ड कैपिलरोस्कोपी तो एवरीबडी वाज साइलेंट. अच्छा ये भी है, तो वो तो ठीक है भाई. मैंने बोल रहा हूँ तुम्हें 50 क्वेश्चंस आर गोना बी लाइक सो इजी कि आप बोलोगे कि मतलब क्यों इतना पढ़ना पड़ा. But then the remaining like 150 are gonna be like, where this can be answered, this can be answered. So I think let's check out your reflexes on 21st as well. Thank you so much for your patience.